Okay, so welcome everyone to the 36th lecture of Dr. Haider Step 1. Can you guys hear my voice? Is everything clear? Okay, welcome and good morning. Hope you guys are doing good. Thank you so much for attending the lecture at 8 a.m. in order to make up for the lost 1 hour, which we had yesterday due to personal reasons. And thank you so much for understanding, and thank you so much for making it to our lecture. First and foremost, for we had a lot of emails for the students who could not find our lectures on Zoom. Okay, you have absolutely nothing to be worried about. We will be uploading the lectures on our Google Drive, so you will have access to all the lectures over there. Okay, so there's absolutely nothing to be worried about. All we did was we removed some videos from the Zoom in order to make some space. That's why we always ask our students to download the videos whenever they get the link. But even if you have not downloaded the video, uh, you will obviously receive them via Google Drive. So you have absolutely nothing to be worried about. Okay, having said that, did you guys do your regular UWorld questions yesterday? Okay, how many questions did you guys do? Very good. 38, 40, 20. Okay. Anyone else? 40. Okay, that is wonderful. Thank you so much. Um, okay, so having said that, it's already been 10 minutes that we have spent in order to wait for everyone to join. Okay, and if we have any new students for our lectures, then all we want to tell them is that we divide our lectures into four segments. That is, in the first segment, we do the revision. The second segment, we do our daily task. In the third segment, we do the UWorld notes. And in the fourth segment, we do the UWorld question. And it's a 4 to 4.5 hour lecture every day. And we will be doing an extra 1 hour today for to make up for the lost time. So that's that. Okay, having said that, let's jump into the first segment of our lecture, that is the revision and recapitulation. Is everyone ready to revise the 3 pages which we covered yesterday? Although those 3 pages, we covered only three, but those were pretty high yield pages. Okay. Okay, good. So let's start with our first question. That is, we will start with the physiology of the proximal convoluted tubule. First of all, I want to know what is the percentage of sodium absorbed from the proximal convoluted tubule? 65, very good. Everyone else? Okay. What is the percentage of sodium absorbed from the distal convoluted tubule? 65 to 80 is the right answer. Okay. The distal convoluted tubule, 5 to 10. Thick ascending limb of loop of Henle. Very good. How about from the collecting duct? Very good. Okay. Okay. And on which two cells of the nephron does aldosterone work in? Aldosterone. Which two segments or which two cells of the nephron does aldosterone work in? Principal and alpha intercalated. Very good. Okay. Okay. Which cell contains sodium potassium 2 chloride channel? which cell contains the sodium potassium 2 chloride channel? Okay, very good. Very good. Okay. Next one is we want to talk about the renal tubular defects. Okay. Can anyone tell me the mnemonics that we learned in order to keep in mind all the causes of Fanconi syndrome? The mnemonic that we created in order to memorize or revise or review all the causes of Fanconi syndrome. Okay, with that being said, what are the causes of Fanconi syndrome? Okay, okay, very good. So with the mnemonic which we used was Wilson tries to hide his candies. With that being said, it's Wilson's disease, tyrosinemia, glycogen storage disease, multiple myeloma, lead poisoning, and nephrotoxic drugs, which contain ifosfamide, cisplatin. Okay, okay, very good. Okay, now we want to talk a little bit about Bartter syndrome. Bartter syndrome. Bartter syndrome, where is the reabsorption defect for Bartter syndrome? Okay, where is the reabsorption defect for Gittleman syndrome? Gittleman. Okay. How about Little syndrome? Little. Can you guys tell me another name of renal tubular defects? Another name? Salt losing nephropathy. Salt losing nephropathy. Very good. Okay. Okay, very good. And with that being said, there's one more thing that I want to revise to see if you guys have understood. Okay, in order for me to do that, I have to open up a blank page. And 1 second. I'm pretty sure you guys know where I'm going with this right now. Okay. All right. If you guys can see my blank page, then the drawing which I'm going for is tubular fluid by plasma. Okay, so that's what I'm going for over here. Tubular fluid by plasma. Okay. Okay. If this is the tubular fluid by plasma, this is 0. This is 1, 2. Okay. I'm sorry. 1 second. 1, 2. This is 0. Okay. Can you guys tell me what A, B, and C stand for? A, B, and C. Okay, good. So A actually should be like this. Okay, A should be like this. B and C. Now, what is A? Is A creatinine or is A urea? A is urea. Very good. B, how about B? Bicarbonate. How about C? C is the glucose or amino acid. Okay. If I draw another one over here, okay. Can you guys tell me which one is D stands for and which one C stands for? D stands for? D stands for? Are you sure D stands for amino acid or D stands for glucose? D stands for amino acid. Very good. Very good. Okay. And C stands for glucose. Okay. Okay, very well. Are we all acquainted with the renin-angiotensin aldosterone system? Do we all know what that is? Okay. Is anyone confident enough to help me out when I explain the renin-angiotensin aldosterone system? Okay. So as a matter of fact, what we would do is, as a matter of fact, what we would do is, instead of unmuting the students, I will ask you guys questions. Do not worry, and you guys can use the chat box for now to answer me the questions which I will ask right now. Okay. In order for us to do that, what we would be doing is we will be starting our regular lecture, that is our daily task at hand, and we will be starting with the renal system, page number, most probably 588. Okay, so page 588. We're going to start from here today. Okay, so let's talk a little bit about the renin-angiotensin aldosterone system, one of the most highest yield mechanisms for a student to master and also to master as a physician. Okay, and I'm pretty sure we all know what this mechanism is. This is basically the blood pressure control mechanism, blood and salt. Okay, very simply put. So we're talking about the renin-angiotensin aldosterone system. Okay, okay. So the first thing is what are the stimulators? Okay, what are the stimulators for renin-angiotensin aldosterone system? Okay, stimulators. Now, number one stimulator is decrease decreased blood pressure. Okay, number two stimulator is decreased salt delivery. Okay, if we have decreased blood pressure, the renin-angiotensin aldosterone system will get activated. If we have decreased delivery of the sodium chloride, then the renin-angiotensin aldosterone system will be activated. And the third one is increase in sympathetic tone, increased sympathetic activity. If we have increased amount of sympathetic activity, if we have increased amount of sympathetic activity, especially by the beta 1 receptor, there will be vasoconstriction. Vasoconstriction will result in decreased blood flow and decreased salt delivery. Decreased salt delivery and decreased blood flow will activate the renin-angiotensin aldosterone system. Okay. Now, first of all, my question is, there are two things that happens over here. First of all, one one cell is responsible for detection. Another cell is responsible for release of the renin. Can you guys tell me which cell of the kidney is responsible for detection of the blood pressure, salt, and stimulation? Very good. The cell that is responsible for detection, D for densa, macula densa. And this cell is located, I'm pretty sure you guys know where this cell is located. This cell is located by the distal convoluted tubule. Okay, this cell is located by the distal convoluted tubule. Okay, this is D, not A. Distal convoluted tubule, and these cells are macula densa cells. These cells are macula densa cells. Okay, these cells will detect the changes. These cells will detect the changes. Okay, now just want to make a proper drawing over here. So we have the afferent that is going all the way to over here, and then efferent. Okay, and this is the glomerulus. Okay, so if the macula densa is responsible for detection, can you guys tell me which cell is responsible for release of the renin? Very good. Juxtaglomerular cells or juxtaglomerular apparatus. Okay. Okay, very good. So we have the juxtaglomerular apparatus over here, the juxtaglomerular apparatus. They will release the renin. They are responsible for the renin release. Okay, this is the juxtaglomerular apparatus. Okay. Now, and this is the macula densa cell, which is present by the distal convoluted tubule. Okay, the fact that they're present by the distal convoluted tubule is heavily tested on NBME. Do not forget, macula densa cells are present on the distal convoluted tubule. They're highly tested on NBME. Okay, so after renin gets released, so right now we have all three of this, or one or two of this problem. So there's release of renin. There's release of renin. Renin. What will renin do? Okay, what will renin do? Can we have some fast answers, please? Renin, what will renin do? Fast answers. What will renin do? Renin will convert which substance to which substance? Fast answers, please. Can you guys hear my voice? Very good. Renin will convert angiotensinogen to angiotensin 1. Okay, angiotensinogen. Is angiotensinogen a protein or not a protein? Which organ is responsible for secreting angiotensinogen? Very good, liver. So renin, what they will do is renin will convert angiotensinogen to angiotensin 1. Angiotensin 1. Okay, so renin will act over here. They will convert angiotensinogen from the liver to angiotensin 1. Angiotensin 1, when angiotensin 1 will circulate in the blood, it will, so the angiotensin 1 that will circulate in the blood, it will go all the way, to the lungs, okay, to the lungs, and some amount will also go to the kidney, okay, and then angiotensin 1 will get converted to angiotensin 2, angiotensin 2. And this angiotensin 2 that is being converted, this is being converted by the enzyme that is angiotensin converting enzyme. Angiotensin converting enzyme will not only convert angiotensin 1 to angiotensin 2, angiotensin converting enzyme will also cause breakdown of a very high yield substance. This substance is known as bradykinin. Angiotensin converting enzyme will cause bradykinin breakdowns. This is the reason why if we give angiotensin converting enzyme inhibitors such as ramipril, lisinopril, patients will get dry cough because angiotensin converting enzyme, which is responsible for the breakdown of bradykinin, cannot break down the bradykinin. As a result, bradykinin accumulation can cause dry cough. Okay, angiotensin 2. Now this angiotensin 2 that is being produced over here, this has multiple actions. Angiotensin 2, this has multiple actions. Okay, so what are the actions of angiotensin 2? Let's go step by step. Okay, first action of angiotensin 2, the first action of angiotensin 2 is on the blood vessels. Okay, is on the blood vessels. Is angiotensin 2 responsible for vasoconstriction? Can we have one physician who can help me out on all the actions of angiotensin 2? Who is confident? Who is confident to help me out on the actions of angiotensin 2? Anyone? Okay, no problem. I'll keep on explaining this and coming back to the chat box. Okay, just okay. So angiotensin 2 on the blood pressure, on the blood vessel. What will it cause? It will cause vasoconstriction. Okay. Next one. Next one is angiotensin 2. Can you guys tell me the mechanism, second messenger system by which angiotensin 2 works? Is it by CMP, CGMP, IP3 DAG? What is the mechanism by which angiotensin works? CAMP, CGMP, CAMP. Okay, very good. So angiotensin 2 they work by the cyclic AMP mechanism. Okay, so they bind to the G stimulatory protein, GS. After they bind to GS, then they activate adenylate cyclase, and then they exert their mechanism of action. Okay, so when they act on the blood vessels, they cause vasoconstriction. Next one is Next one is, will angiotensin 2 cause vasodilation or vasoconstriction of the efferent arteriole? That is my question. Let's say that this is the glomerulus, and this is the efferent, this is the efferent. Will angiotensin 2 cause will angiotensin 2 cause dilatation or constriction? Constriction of the efferent arteriole. If we have constrictions of the efferent arteriole, will it cause increase of GFR or decrease of GFR? GFR. GFR will decrease. That is not correct. GFR will increase. GFR will increase. Okay. GFR will increase. When GFR increases, what would happen to the filtration fraction? What would happen to the filtration fraction? Filtration fraction, that is GFR by renal plasma flow. Filtration fraction will also increase. So constriction will cause, afferent arteriolar constriction will cause increase of GFR, increase of filtration fraction. Okay. If we have a patient who is in shock, if we have a patient who is in a circulatory shock, okay, in those patients, do we have a patient with a high blood pressure or with a low blood pressure? Patients in shock, low blood pressure, okay. In low blood pressure, efferent arteriolar constriction, if we have efferent arteriolar constriction of the kidney, will this preserve the function of the kidney? Yes or no? Yes. Okay. So this is the reason. So preservation of the renal function in a patient of shock or in a patient with low blood pressure why um, is the reason why angiotensin 2 causes efferent arterial constriction. Okay. Next one is, do you guys remember that we talked about a sodium hydrogen antiporter on the proximal convoluted tubule? Sodium hydrogen antiporter on the proximal convoluted tubule. Yes. Do you guys remember that we said that angiotensin 2 will activate the sodium hydrogen antiporter in the proximal convoluted tubule? So what will they do? Proximal convoluted tubule. The angiotensin 2 will increase the activity of the sodium hydrogen antiporter. Antiporter. Okay. If we have increased activity of the sodium hydrogen antiporter, do we have acidosis or alkalosis? Acidosis or alkalosis? Alkalosis. Very good. This alkalosis that is caused by the angiotensin 2 on the proximal convoluted tubule by the activation of the sodium hydrogen antiporter, this alkalosis is called contraction alkalosis. Contraction alkalosis. Okay. Next one. After angiotensin 2 does all of these work, angiotensin 2 itself will activate another substance. Angiotensin 2 will activate another substance. This substance, angiotensin 2, will go to the, okay, if, let's say this is your kidney, then we have a gland over here, right? We have this fatty gland over here. What is the name of this gland? Fast answers, please. Adrenal glands. Very good. So when angiotensin 2 will go to the adrenal glands, angiotensin 2 will cause secretion of a very high yield substance. What is that substance? Aldosterone. Angiotensin 2 will cause secretion of aldosterone. Okay. When aldosterone is secreted, aldosterone itself, what will aldosterone do? First of all, aldosterone will go to the principal cells and the alpha intercalated cells. It will cause decreased reabsorption of potassium. Am I correct? Yes or no? Decreased reabsorption of potassium or decreased reabsorption of sodium? Which one? Very good. Decreased reabsorption of potassium. Will aldosterone increase the sodium reabsorption? Yes. Okay. Aldosterone will increase the sodium reabsorption by increasing the activity of the sodium potassium ATPase pump. Aldosterone, on the other hand, will work also in the alpha intercalated cells. When aldosterone works in the alpha intercalated cells, will aldosterone increase the activity of the hydrogen ATPase channel? Yes or no? Alpha intercalated cells. Okay, so if a patient has increased activity of the hydrogen ATPase channel, will the patient have alkalosis or acidosis? Alkalosis. So aldosterone will go and work in two places, that is the principal cells and the alpha intercalated cells, okay, and cause their effect. If we have a patient with increased amount of aldosterone activity and sodium is reabsorbed, will water be also reabsorbed with sodium? Fast answers. Okay. If water is reabsorbed, then do we have correction of the blood pressure? Yes, very good. So the main problem, the primary problem was decrease of blood pressure and decrease sodium chloride. So are those things corrected finally by the renin-angiotensin aldosterone system? Yes. So those things are corrected. Okay. Those things are corrected. Okay. Angiotensin 2 will has another small effect. Okay. This effect is not very widely talked about, but it's a pretty high yield effect. What angiotensin 2 does is angiotensin 2 also goes to another organ. Okay. This organ is known as the hypothalamus. Angiotensin 2 will go to the hypothalamus and, okay, 1 second. Angiotensin 2 will go angiotensin 2 will go to the hypothalamus, and angiotensin 2 will also go to another organ. This organ is known as the posterior pituitary gland. So in the neurological system, they will go to two organs, that is the hypothalamus, another one is the posterior pituitary. When they will go to the posterior pituitary, angiotensin 2 will cause the release of a very high yield hormone, that is ADH, high yield hormone, that is ADH. Another one that is that when they will go to the hypothalamus, they will activate the thirst center. So patients who have decreased blood pressure will eventually they will get thirsty and they will drink water, blood volume will increase, and the blood pressure will get corrected. Are we clear on this? Okay. Okay, so that is basically the renin-angiotensin aldosterone system. Okay. What is renin, basically? Okay, let's read the text. Let's see what the text says. The text says that basically renin is secreted by the juxtaglomerular cells in response to renal perfusion, detected by renal baroreceptors in the efferent arteriole, increased renal sympathetic discharge, and decreased sodium chloride delivery. Everything that we have discussed over here, secreted by the juxtaglomerular cells. This is high yield. Okay, this is very high yield. Next one is angiotensin 2. Angiotensin 2. Next one is angiotensin 2. Angiotensin 2 helps maintain the blood volume and the blood pressure. We know that by ourselves. Affects the baroreceptor function, that is the pressure functions. Okay. Over here, what happens is when we have decreased blood flow, then there's decreased stretching. If we have decreased stretching, then there's decreased activity. I mean, decreased stimulation. Okay. And this decreased stimulation, this decreased activity results in increased release of the renin. Vice versa, on the other hand, if we have increased blood pressure and there is increased amount of stretching, this increased stretching will cause decreased release of the renin. So this is the baroreceptor function. This is the baroreceptor function of the kidney. Okay, so that's what they're talking about, the baroreceptor function. Angiotensin 2, on the other hand, they help maintain the blood pressure and the blood volume, affects the baroreceptor function, limits reflex bradycardia, which would normally accompany its pressor effects. If we have a patient with reflex bradycardia, will there be increased activity of the renin angiotensin aldosterone system or decreased activity? Bradycardia, increased activity. So can bradycardia be corrected by the renin-angiotensin aldosterone system? Okay, good. Next one is atrial natriuretic peptide and brain natriuretic peptide. They are released from the atria, and another one is released from the ventricles. In response to increased volume, it inhibits the renin-angiotensin aldosterone system, relaxes the vascular smooth muscle via CGMP. Okay, we know that the hormones that use CGMP are three, that is ANP, BNP, and nitric oxide. Okay, we learned about this in endocrinology. They will increase the GFR and decrease the renin, dilates efferent arteriole, promote natriuresis. Okay, now there's a very high yield topic which I want to talk about, the very high yield topic. First of all, what we have is we have the renin angiotensin aldosterone system. There you will have multiple, if not 10 to 20 questions or more about aldosterone escape. Okay, aldosterone escape. Okay, can we have any active participant who can help me out with these questions about the aldosterone escape? Okay, Dr. Hassan. Yes, okay. Okay. So Dr. Hassan, would you be kind enough to unmute yourself and let's see if you can answer these questions? Okay,
Yes, doctor.
perfect. Okay, so my
Mhm.
question is, first of all, if you have a patient with decreased amount of blood pressure, if you have a patient with decreased amount of blood pressure, will there be increased activity of the renin-angiotensin aldosterone system? Yes or no?
No, decrease.
No, if we have decreased blood pressure,
Okay,
will
okay. Because
will there
okay. So androtensin system will be increased, activated.
be, right, very good. So there will be increased activation of the renin-angiotensin aldosterone system. Okay.
Mm-hmm.
Right now, if we have increased aldosterone activity, increased aldosterone, will there be more sodium or less sodium?
Initially, there will be more sodium. Yeah.
More sodium, very good. Okay, so the sodium will increase. So what would happen is, okay, so what would happen is if you have a patient with decreased amount of blood pressure, so what is aldosterone escape? Aldosterone escape is the mechanism in which in patients with low amount of blood pressure, increased activity of the renin-angiotensin aldosterone system should have caused increased amount of sodium in the blood. That is hypernatremia. Okay, but for the mechanism of aldosterone escape, the sodium level in the blood remains at a normal level. Why does that happen? That happens because if this increased amount of blood volume, when when this goes when this goes to the heart, okay, when this increased amount of blood volume, when this go to the heart, they go to the atria, they go to the ventricles, okay? And stretching of the atria causes release of a very high yield hormone, that is ANP. So stretching of the ventricles causes the release of a very high yield hormone, that is BNP, okay? So this ANP and BNP that is being secreted, this ANP and BNP, they work in the, they, what they do is they work in the kidney, and they decrease the reabsorption of the sodium. Now, my question to you, Dr. Hossam, is in which portion of the kidney does the ANP and BNP work in order to decrease the sodium reabsorption?
In collecting tubules.
So basically, they increase the reabsorption of water in the collecting ducts. Okay. But I want to know which portion of the kidney does ANP and BNP work from where they can decrease the reabsorption of the sodium. Do we have any other answer from anyone else? Let's say in the chat box. Which portion does ANP and BNP work in order to decrease the reabsorption of sodium? Okay. Okay. So ANP and BNP basically, primarily, they work in the proximal convoluted tubule. From the proximal convoluted tubule, where the maximum amount of sodium is reabsorbed, they work in the proximal convoluted tubule to decrease the reabsorption of the sodium. As a result, what happens is there is high amount of sodium natriuresis. There is high amount of sodium natriuresis. So this increased amount of sodium that should have been the case in increased amount of aldosterone, this actually decreases to a normal level. This actually decreases to a normal level. Okay, normal level. Okay. Now you will receive questions in UWorld where they will ask you, where they will tell you that you have a patient where there is increased amount of renin-angiotensin aldosterone activity. What do you expect the sodium level to be? Increased, decreased, or normal? What should be your answer? What should be your answer? Increased, decreased, or normal? Normal. Okay. So this is known as aldosterone escape. Are we absolutely clear about aldosterone escape? Okay. Okay. Have you guys already received questions in UWorld regarding aldosterone escape? Okay. If you guys have received questions about aldosterone escape in UWorld, I can guarantee you will receive more questions in the future. And also you might receive these questions in your actual step 1 exam because this is highly, highly tested. Okay, next one. Next one is ADH. ADH primarily, they will regulate the serum osmolarity. They respond to low blood volume, stimulate the reabsorption of water. Okay. What is the receptor for ADH for increasing the reabsorption of water? Can I get some fast answers? V2 receptor. Very good. Also stimulates reabsorption of urea in the collecting ducts to maximize corticopapillary osmotic gradient. This is absolutely important. This is very, 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 very important. Okay. Okay. So what we will discuss right now is that there's this mechanism in the medullary in the medullary section, that is when we have to do we have to maintain a hypertonic state of the renal medulla or a hypertonic state of the renal medulla? Hypotonic or hypertonic? Why do we have to maintain a hypertonic state? Hypertonic. These are very basic questions. Why do we have to maintain a hypertonic state? To concentrate the urine. Okay, absolutely wonderful. That is exactly what I wanted to hear, to concentrate the urine. Okay, so first of all, okay, we have the proximal convoluted tubule. Okay. 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 So what's going on over here is that what's going on over here basically is, okay, Okay. My question to you is, we have A, B, and C. Which one of these have the highest medullary concentrations for increasing the concentration of the urine? Okay, C. Okay. So the thing is, the surrounding area, okay, so this area is very concentrated. Okay, this area is very concentrated. Why is this area so concentrated? This area is concentrated to increase the reabsorption. Okay, to increase the reabsorption of what? Mostly water and salt and all those other things. Okay, and the thing is, this area, what this contains is, this area contains a high amount of a substance that is urea. Okay, so urea is very high over at this area. The substance that is responsible, that is urea, it increases in the medulla, these segments, with the help of ADH. ADH, what this does is, ADH increases the absorption of urea. So let's say blue stands for urea, blue. Okay, urea will keep on going over here. Okay, and then over there the urea will recycle back via the blood, and then again they will come through over here. When they go through over there, small amount will pass through, and most of it will be present over here to increase the concentration of the medulla. This medullary concentration, increase in medullary concentration, will increase the reabsorption, will help in the increase of reabsorption of substances. And the hormone that is responsible for increasing the concentration of urea is ADH. Are we clear on this? Are we clear on this? How important is this? Is this little piece of information? Okay, this little piece of information is very, very, very important. You guys will receive questions on this, the NBME, and in UWorld. For okay, for everyone. So
Doctor, can you repeat, please?
Of course, yes, of course, I can repeat, no problem. Okay, so what's happening is, so we have a very high yield hormone, that is ADH. First of all, ADH is released from the posterior pituitary. ADH will increase the reabsorption of water from the collecting duct via the V2 receptor, and ADH will also increase the increase the secretion of the urea in the medulla. Okay, so this portion is the medullary portion. Okay, so they will increase the concentration of urea, or as a result, the concentration of the substances in the medulla will increase. When we have increased concentration of the medulla, this will result in increased reabsorption of water and all the other substances and as a result, when we have reabsorption of water from the urine will get concentrated. So concentration of the urine is important, and concentration of urine is done by reabsorption of water due to the increased medullary concentration of the kidney. That is A, B, C. These are the three different segments of the medulla. And this C over here has the highest amount of concentration because this portion surrounding the nephron, they have a high amount of urea due to ADH.
Okay, so it increase also the reabsorption of urea.
Yes.
Stimulate the reabsorption of urea.
Yes, they stimulate the reabsorption of urea in the collecting duct to maximize the corticopapillary osmotic gradient. Okay, and okay, that's that. You are absolutely welcome. Okay, and okay, if you guys have any question, please use the chat box. We will answer it for you, no problem. Okay, next one. Next one is aldosterone. Aldosterone, primarily, they will regulate the ECF volume and the sodium content, increase release and decrease blood volume states. We all know what this is. This responds to hyperkalemia by increasing the potassium excretion. Okay, are we clear on all the information from the last page? Very high yield informations. Are we clear on all those informations? Angiotensin 2 and bradycardia. Okay. Okay. Angiotensin 2 and bradycardia. Okay. Angiotensin 2, if we have decreased amount of blood pressure, or if we have decreased amount of blood flow, for example, decreased blood flow occurs in bradycardia, we have increased activation of the renin-angiotensin aldosterone system. As a result, angiotensin 2 increases in bradycardia. That's number one. Number two is ANP. ANP, when we have increased amount of aldosterone activity, increased amount of sodium, and there's increased sodium in the blood and increased blood volume. This blood volume stretches the atria of the heart, and there are release of a very high yield hormone, which is ANP. ANP works with the proximal convoluted tubule to decrease the reabsorption of sodium, and this causes high amount of sodium loss. But as a result, the sodium in the blood, it remains at a very normal level, because aldosterone increases the sodium and ANP decreases the sodium. This mechanism is known as aldosterone escape. As a result, the serum sodium level remains at a normal level. Okay, so that is exactly what you have to know. Are we clear on this? Okay, are we clear on this? Yes or no? Can we move to the next page, please? Can I have some feedbacks? Do I have some feedbacks? Okay, very well. Next one is they want to talk a little bit more about the juxtaglomerular apparatus. That is, they consist of the mesangial cells, juxtaglomerular cells, and the modified smooth muscles, which are the modified smooth muscles of efferent arteriole. Okay, please underline this portion over here. That is, juxtaglomerular cells are the modified smooth muscle of the efferent arteriole. Okay, you guys will be tested on this. That is, juxtaglomerular cells are basically the modified smooth muscle, meaning the smooth muscles which can secrete any substance is known as a modified smooth muscle. And the macula densa. Macula densa, once again, is the sensor, is the detector, and juxtaglomerular cells are the secretors. Okay, so these two together are known as the juxtaglomerular apparatus. And the macula densa. Macula densa is basically the sensor, that is a sodium chloride sensor. Once again, they're located at the distal end of the loop of Henle. They're also located at the distal convoluted tubule. Okay, juxtaglomerular cells secrete renin in response to low blood pressure. We already discussed about that, and increased sympathetic tone. They sense decreased sodium chloride delivery to the distal convoluted tubule. Okay, so we have already talked about these things. They increase the renin. They cause efferent arteriolar vasoconstriction and GFR via angiotensin 2. Okay, juxtaglomerular apparatus maintains the GFR via renin-angiotensin aldosterone system. In addition to vasodilatory properties, beta blockers can decrease blood pressure by inhibiting the beta 1 receptors of the juxtaglomerular apparatus and decreasing the renin release. Okay, will increased sympathetic activity increase the renin-angiotensin aldosterone system or decrease the renin-angiotensin aldosterone system? Fast answers, please. Increase sympathetic activity, increase. Will having beta blockers decrease the sympathetic activity or increase the sympathetic activity? Decrease. If we have decreased sympathetic activity via the beta blockers, will beta blockers increase renin release or decrease the renin release? Decrease. Very good. Okay, so please keep that in mind. That is a very high yield association. Okay. Next one I want to talk about is erythropoietin. Erythropoietin, the cells, these are released by interstitial cells in the peritubular capillary bed in response to hypoxia. Release of erythropoietin, where is erythropoietin released from? They are released from the peritubular capillary bed. This is very important. Interstitial cells in peritubular capillary bed in response to hypoxia. What is peritubular? What are the peritubular capillaries? Okay, so all the substances that are reabsorbed from these segments, they go to a nearby capillary, that is this capillary over here. This capillary that is peripheral to the tubule, that stays in the peripheral of the tubule, are known as peritubular capillaries. These capillaries are responsible for carrying the reabsorbed substances from the nephron to the circulatory system. Okay, and these capillary beds, they have a very special cells. They have a very special cell known as interstitial cells. Interstitial cells in these capillary, they are responsible for the release of a very high yield hormone, that is erythropoietin. Erythropoietin is responsible for stimulation of RBC in the bone marrow and administration of erythropoietin secondary to chronic kidney disease. Okay, we also administer erythropoietin secondary to chronic kidney disease, because in chronic kidney disease, these cells fail and erythropoietin is not released. As a result, patients get anemia, and these anemias are anemias The anemia that we see due to decreased amount of erythropoietin, is it microcytic or macrocytic? Microcytic or macrocytic? Anemia that we see in kidney diseases. Normocytic anemia or microcytic anemia or macrocytic anemia. Okay, so initially they are normocytic. Initially, these anemias are normocytic anemia. If these anemia they can, I mean, if the anemia is not corrected, if they stay for a long period of time, then these anemias can get transformed into anemias of chronic kidney disease, or like anemias, anemia of chronic disease. And anemia of chronic disease is the microcytic anemia. So initially normocytic, and then eventually microcytic. Okay. Okay. Next one. Next one is calciferol. Calciferol is secreted by the proximal convoluted tubule. They convert the 25 hydroxy vitamin D3 to 125 hydroxy vitamin D3 via, via which hormone? The hormone that is responsible is parathyroid hormone. Parathyroid hormone, proximal convoluted cell, they contain a very high yield enzyme. We talked about this in the endocrinology. This enzyme is known as 1-alpha hydroxylase. They convert 25 hydroxy D3. Please remember this. You will be tested on this. That is 25 hydroxy D3. This is the chemical equation. I mean, the chemical name for calcidiol, which is the inactive form, and 125 dihydroxy D3 is the activated form, and this is for calcitriol. Okay, and the hormone that is parathyroid hormone, they activate 1-alpha hydroxylase, which activates this. So we already talked about this once. Prostaglandin, okay, we know that PDA, do you guys remember PDA? PDA is prostaglandin dilates the afferent arterioles. So prostaglandin dilatation of the afferent arterioles will increase the renal blood flow. And as a result, if we use NSAID, that is non-steroidal anti-inflammatory drug, they will cause decreased release of prostaglandin. Decreased release of prostaglandin will cause constrictions of the afferent arteriole, decreasing in GFR. This may result in acute kidney injury in low renal blood flow states. Okay, prostaglandin. Next one is dopamine. Okay, dopamine is secreted by the proximal convoluted tubular cells. Dopamine promotes natriuresis. At low dose, they dilate. Okay, so basically the questions that you will receive from the UWorld, from these ones, I've already told you this. This is the question number 1. Before I move on to any forward, I want to discuss the questions you will receive. This is question number 2. That is parathyroid hormone activates 1-alpha hydroxylase. And this is question number 3. That is, what is the activated form? What are the formulas? Okay, question number 3. Question number 4 is prostaglandin. What does it do? Dilate or constrict? They cause dilatation. And NSAID can cause decrease in GFR. Okay, this is question number 5. Okay, that the fact that NSAIDs can cause decrease in GFR by decreasing the release of prostaglandins. Next one is dopamine. Dopamine is secreted by the proximal convoluted tubule. Dopamine also promotes natriuresis. At low dose, they will dilate the interlobular arteries, afferent arterioles, and efferent arterioles and increase the renal blood flow. Little or no change in GFR. At higher doses, they act as a vasoconstrictor. Okay, over here, you will not receive any questions about dopamine, more or less, very less yield. If you have to receive one question, they would want to know that dopamine at low dose causes dilatation and at high dose causes vasoconstriction. Okay, do we have any questions from anyone? Okay. So, so repeat the important note on ADH from the previous page. Important notes about ADH from the previous page was ADH increases the urea concentration in the medulla for for concentrating the urine. That is all you have to know. If you get asked that ADH, which two substances are increased in reabsorption by ADH, what is your answer, everyone? Which two substances increases as a result of ADH activity? Water and urea. Very good. That is exactly what it is. So if you can remember this piece of information, that is all you have to know. Are we clear? Okay. 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 Next one is. Next one is. Okay. This segment over here. Okay. Next one is this segment over here. Okay. So we will be talking about the hormones that work on the kidney. Okay. The hormones that work on the kidney. Okay. So first of all, let's talk a little bit about atrial natriuretic peptide to see where it works. Atrial natriuretic peptide, they're secreted in response to increased atrial pressure. We keep in mind that we have just talked about all these hormones. We're just doing a quick revision to see if we all stand on the same page. Okay, these hormones, what you can do is you can look at this diagram and do a quick revision to see if everything is okay and if there's anything new that you have to understand or no. ANP is basically secreted to increase natriuretic peptide, increase atrial pressure. They will increase the GFR and sodium filtration with no compensatory sodium reabsorption in the distal nephrons. In distal nephrons, they will not cause sodium reabsorption. Okay, in the distal convoluted tubule. ANP also works to some extent in the proximal convoluted tubule and in the distal convoluted tubule, and they will cause the net loss of the sodium. Okay, the net effect is sodium loss. Next one is angiotensin 2. Angiotensin 2, they're synthesized in response to decreased blood pressure, causes efferent arterial constriction. If you get a question about which two segments of the, or which segment is primarily responsible for ANP activity, ANP, which two segments does ANP work in? Distal convoluted tubule and proximal convoluted tubule. Okay, that is your answer. Next one is angiotensin 2. They are synthesized in response to decreased blood pressure, increased GFR and filtration fraction, with compensatory sodium reabsorption. Net effect is preservation of the renal function in low volume state. We talked about that. Parathyroid hormone, where does it work? Parathyroid hormone, they work in the proximal convoluted tubule. Once again, what is the enzyme that is responsible? Enzyme that is responsible for proper functioning of the parathyroid hormone? Which enzyme is responsible for proper functioning of the parathyroid hormone, please? Do I have any feedback? Do you guys remember the name of the enzyme in proximal convoluted tubule? Thank you so much. The name of the enzyme is 1-alpha hydroxylase. 1-alpha hydroxylase. Okay, the 1-alpha hydroxylase activity. Let me see if you guys remember parathyroid hormone well. Excuse me. Okay. Parathyroid hormone, they work in the proximal convoluted tubule. They activate the 1-alpha hydroxylase enzyme, which converts 25 hydroxy D3 calcidiol to calcitriol. What happens in the next step? How does that help in calcium, increasing the serum calcium level? How does calcitriol increases the serum calcium level? This is a very basic information. Very good. Okay, gut absorption. Gut does not have any reabsorption. Gut only has one absorption. So that is, they will increase the calcium absorption from the gut. They will cause calcium absorption from the gut, not reabsorption. Reabsorption is only done in the kidney. Absorption is what happens in the gut. Okay, so very good. That's exactly what it is. Along with that, they will cause PTH, is also known as phosphate thrashing hormone. That is, they will deactivate the sodium phosphate channels over here, and they will cause decreased reabsorption of phosphate. Okay, next one. Next one is aldosterone. They're secreted in response to decreased blood volume. We have already discussed about this, increasing the potassium and hydrogen secretion. As a result, patients can be hyperkalemic and have metabolic alkalosis. ADH is responsible. They're secreted in response to increased plasma osmolarity. They work on the principal cells, causing increasing the number of aquaporins and increasing the reabsorption of urea in the collecting ducts to maximize the cortico-papillary osmotic gradient. Once again, two things that urea causes. Two things that urea causes. I mean that ADH increases in terms of reabsorption is water and urea. Water and urea. Okay. Are we clear on this, on the hormones of the kidney? Do we have any questions? Do we have any questions from everyone else? Yes or no? Do we have any questions from the kidney, the hormones, yes or no? A and P. Okay. Which portion does NP work in? Okay. Okay. Which portion does ANP work in? ANP, atrial natriuretic peptide, they work in the proximal convoluted tubule and in the distal convoluted tubule. Okay? Is that clear? They work in the proximal convoluted tubule and distal convoluted tubule, not in the collecting duct. Are we clear on this? ADH. ADH, they work in ADH, they work in. Where does ADH work in? We already discussed about this. Where does ADH work in? Collecting duct. There we go. Collecting duct. Any other question? Any other question? Okay, can I ask you guys one piece of question? What is the only hormone in the kidney which works in the medullary portion of the kidney? Which hormone works only in the medullary portion of the kidney? Very good. This, okay. Okay. Please write it down. This is an NBME question. This is a question asked in your NBME. Okay. Which hormone works in the medullary portion of the kidney? And the answer is ADH. Every other hormone, more or less, acts at the cortical portion of the nephron. Okay. Are we clear? Okay. Next one. There's this one thing I want to talk about. I want to talk about potassium. Okay. Potassium. Okay. Okay. So this is the house of potassium. Okay. This is the house of potassium. Okay. So let's see what's happening over here. Okay. So this is the house of potassium, basically. Okay. The thing is, if we have, if we have, if this is a road, okay, and let's say potassium is walking on the road, okay. If potassium is walking on the road, and let's say someone comes and pushes potassium inside the house. Someone comes and pushes potassium inside the house. pushing potassium or pushing anyone for that matter, is this a good habit or a bad habit? Pushing people, good habit or a bad habit? It's a bad habit. So basically, habit. Okay. Okay. So pushing potassium inside the house or shifting of potassium inside the cell. Okay. Habit stands for, you guys know where we're going with this. Okay. Okay, because we love making mnemonics. Habit. Habit H4, hypoosmolarity. A4, alkalosis. B4, beta beta adrenergic agonist. I4, insulin. I for insulin. And T is, there's no cause for T. Okay, there's no cause for T, just these four over here. Hypoosmolarity. How does hypoosmolarity cause decrease, cause increased shifting of potassium inside the cell? Does anyone have any idea? Hypoosmolarity. Shifting of potassium inside the cell. How does that happen in hypoosmolarity? Anyone? Hypoosmolarity. Shifting of potassium inside the cell. How does that happen? Okay, how does alkalosis cause shifting of potassium inside the cell? Anyone? Hypoosmolarity and alkalosis. How does that happen? Does anyone have any idea how hypoosmolarity causes potassium shifting inside the cell? Okay. If we have a patient with hypoosmolarity, if we have a patient with hypoosmolarity, so let's talk a little bit about sodium concentration. Let's talk a little bit about sodium concentration. Is sodium concentrations is sodium high intracellularly or extracellularly? If we have hypoosmolarity, does that mean that there's decreased amount of sodium? Yes or no? So if we have decreased sodium, can there be increased activity of the sodium potassium ATPase pump? Yes or no? If the sodium potassium ATPase pump does not work, will there be more shifting of potassium inside the cell or less shifting of potassium inside the cell? Sodium potassium ATPase pump, does it cause, my question is, sodium potassium ATPase pump, does it cause shifting of potassium inside the cell or outside the cell? Okay. If we have decreased activity of the sodium potassium ATPase pump, will there be more potassium outside the cell or inside the cell? So as a result, what happens to the serum potassium level? Okay. But in a patient with hypoosmolarity, okay, if we have increased amount of potassium in, okay, if we have increased amount of potassium, if we have increased amount of potassium outside the cell, what hypoosmolarity does is, in hypoosmolarity, this causes increased shifting of the potassium. Okay, so you're confused, no problem, I'll clear the confusion right away. What happens in hypoosmolarity is, if we have a patient with hypoosmolarity, the serum osmolarity is already decreased. Okay, so as a result, what happens is, in hypoosmolarity, there is absolutely more or less no proper functioning of the sodium potassium ATPase pump. Sodium potassium ATPase pump does not work properly. In hypoosmolarity, what this causes is, this this results in shifting of the potassium from the extracellular environment to the intracellular environment to maintain the cellular homeostasis. As a result, what happens is, the potassium from the extracellular environment, they enter into the cell to maintain the sodium potassium ATPase level. That's the same thing that happens, for example, in insulin. If we have increased amount of insulin, does it activate the sodium potassium ATPase pump? Yes or no? If insulin increases the sodium potassium ATPase pump, does it push more potassium inside the cell or outside the cell? More potassium into the cell. So the potassium increases inside the cell. The same thing happens if we have a patient with increased amount of alkalosis. Do they have more hydrogen or less hydrogen? Alkalosis, less hydrogen. So will this activate the hydrogen potassium ATPase pump? Yes or no? Yes. So if hydrogen increases, if they try to increase the hydrogen outside, do they have to increase the sodium? I mean, do they have to increase the potassium shift inside the cell? Yes or no? In order for hydrogen to get released? Okay. So that's that. Are you guys clear now? Are you guys clear now? Okay. Where do you guys have confusion? Okay. Let's break this down. Okay. Let's break this down. Okay, first of all, in hypoosmolarity, this is the number one problem of confusion. Okay, let's talk about hypoosmolarity. If we have hypoosmolarity, okay, if there's a patient with hypoosmolarity, what does that mean that these patients, if we have a patient with hypoosmolarity, does that mean that, let's say that this is your blood vessel, if it's a hypoosmolar blood vessel, does that mean that there's a possibility that you might have increased amount of blood volume? Or because hypoosmolarity can occur when the potassium in the blood is diluted. Am I correct or am I not correct? Let's forget everything and let's talk from the beginning. If we have a hypoosmolar patient, does increase in blood volume cause hypoosmolarity? That is my first question. Let's say you have a patient with a high amount of blood volume, the water content is high. There's increased amount of blood volume, the water content is high. Does that mean that these patients have hypoosmolarity? Yes. And if blood volume is increased, then the blood is diluted as a result of the dilution of the blood vessels. I mean, as a result of the dilution of the blood, the potassium in the the overall serum sodium, potassium, and all the ions, they decrease because the blood is diluted. Now, let's say this high amount of blood volume, this diluted blood, reaches the kidney. Will there be more activation of the renin-angiotensin aldosterone or less activation? high blood volume. Okay, so this high blood volume, when, okay, so this renin-angiotensin aldosterone system, okay, when this will work, will, so if, so will there be more release of aldosterone or less release of aldosterone? And what about angiotensin 2? Angiotensin 2. Okay. Overall, every hormone, angiotensin 2, aldosterone, they will decrease. If we have low amount of aldosterone that is working, will there be more potassium secretion or less potassium secretion into the urine? Less potassium secretion in the urine. So overall, what would happen is there will be a slight in there will be an increase of potassium inside the blood. Am I correct? As a result of low aldosterone, yes or no? Okay. So when we have increased amount of potassium as a result of increased blood volume, this increased amount of this slight increase in the potassium ion, what this will do is this will hamper the homeostatic level of the blood, and as a result, this high potassium in the blood due to decreased activity of the aldosterone due to hypoosmolarity will shift the potassium from the blood into the cell to maintain the cellular homeostasis. Am I? Is it clear now? Yes or no? Okay, next one. Next one is alkalosis. Next cause of shifting potassium inside the cell is alkalosis. In alkalosis, do we have high hydrogen or low hydrogen in the blood? Hydrogen, low amount of hydrogen. So in a cell, this is the hydrogen potassium ATPase pump. If hydrogen has to leave the cell in order to increase in the blood, and potassium has to enter the cell, in alkalosis, will there be increased activity of the hydrogen potassium ATPase pump or decrease activity? Increased activity of the hydrogen potassium ATPase pump or decreased activity? Increased activity. If there is increased activity of the hydrogen potassium ATPase pump, will more potassium move inside the cell in order to get the hydrogen outside of the cell? Yes or no? Okay, very good. Alkalosis. Okay. The same way, in another one, that is beta adrenergic agonist and insulin, these two, what they do is they directly activate the sodium potassium ATPase pump. Sodium potassium ATPase. This is one of their function, that is they activate the sodium potassium ATPase pump. If they activate the sodium potassium ATPase pump, will more potassium move outside of the cell or inside of the cell? Inside of the cell. Okay. So is it a bad habit or a good habit to push potassium inside the cell? The mnemonic, bad habit. So what are the causes of potassium shifting inside the cell? Now what is your answer? H4. Fast answers, please. Can we get some fast answers? Osmolarity. A4. A4. Alkalosis. B4. B4. Beta adrenergic agonist. I4. Insulin. Are we clear on this? Yes. Are we clear on this? Yes or no? Okay, good. Next one. Next one is, next one is, okay. We have, next one is we have a lab assistant, okay. We have an assistant in the lab, okay. So this assistant in the lab, okay, she is very concerned, okay. This is her research table. Okay, she is very concerned because she has a patient. She has a patient who has high potassium in the blood. Her potassium level is in the her potassium level in the blood is very high. Okay, so this high potassium level in the blood, okay, which is causing hyperkalemia, she is very concerned. So what she is doing is she is doing some lab work or research work to understand why the potassium in the blood is high. Okay, so what is she doing? She's doing labs. Okay, so do labs. She's a lab assistant. She's doing her work to understand why her patient's why her patient's potassium in the blood is high. Do labs. Do labs stand for D for digitalis. Digitalis. What does digitalis do? Digitalis blocks the sodium potassium ATPase. Okay, digitalis, they block the sodium potassium ATPase pump and decrease action of the sodium potassium ATPase pump results in increased activity of the sodium calcium exchanger. As a result of the fact the calcium increases, and then there is chronotropic activity, inotropic and chronotropic activity. Do you guys remember the mechanism of action of digitalis? Yes or no? Yes or no? Digitalis. We talked about this in the cardiovascular system. Okay. So if we block sodium, if digitalis blocks the sodium potassium ATPase pump, will there be more potassium inside the blood, or I mean, outside of the cell or inside of the cell? Outside of the cell. It will shift potassium outside of the cell. So more potassium will stay outside. So digitalis is number one. Next one is next one is okay. Next one is hyperosmolarity. Hyperosmolarity. Okay. Next one is hyperosmolarity. And vice versa, how hyperosmolarity shifts potassium inside the cell, hyperosmolarity will shift potassium outside of the cell. Next one is next one is lysis. Lysis or tumor lysis. Lysis is basically if there is a cellular breakdown, or let's say, for example, there are different types of lysis syndrome. For example, there's rhabdomyolysis, then there's tumor lysis. Whenever there is breakdown of a cell, this releases a huge amount of potassium from inside the cell to the outside of the cell. And so lysis is a very high yield cause for hyperkalemia. Okay, next one. Next one is acidosis. Do you remember how alkalosis caused hypokalemia? Acidosis will cause decreased activity of the hydrogen potassium ATPase pump. As a result, they will shift potassium outside of the cell. So acidosis. Next, A for acidosis. And the exact opposite was alkalosis, how alkalosis caused increased activity of the hydrogen potassium ATPase. So more potassium shifted inside the cell, and the exact opposite happened in acidosis. Next one is beta blocker. Okay, beta blocker, beta adrenergic agonist can cause increased activity of the sodium potassium ATPase. So beta blocker will cause decreased activity of the sodium potassium ATPase. That's that. S4 S4 succinylcholine. Succinylcholine. Succinylcholine, muscular relaxant, that is a depolarizing relaxant. So succinylcholine can cause shifting of the potassium outside the cell. Okay, so that's that. Another one is high blood sugar. High blood sugar. In high blood sugar, we have insulin deficiency. Insulin usually shifts the potassium inside the cell, right, by increasing the activity of the sodium potassium ATPase. And high blood sugar, in which there is decreased insulin, will cause decreased activity of the sodium potassium ATPase, and potassium will shift outside of the cell. Okay, do labs. So once again, shifting of potassium out of cell, research assistant doing her labs, D for digitalis, O for hyperosmolarity, L for lysis, A for acidosis, B for beta blocker, S for succinylcholine, and S for increased amount of blood sugar. Are we clear on this? Okay. What are the causes of potassium shifting inside the cell causing hypokalemia? Or what are the causes of hypokalemia? Very good. Hypoosmolarity, then alkalosis, B4, fast answers, B4, B4, beta agonist, I4. Okay. What are the causes of hyperkalemia? Hyperkalemia, two labs, for digitalis, O4, D for digitalis, O4, hyperosmolarity, L4, L for lysis, A for acidosis, right? A for acidosis, B4, beta blocker, S4. Okay. Are we all clear on this? Okay. Will we ever make mistakes regarding hypokalemia and hyperkalemia? Okay. So, bad habit to push potassium inside the cell. Bad habit for habit for that, and research assisted doing labs for her research for her patient who has hyperkalemia. So do labs. So that's that. Okay. Okay. What are the causes of Fanconi syndrome? What are the causes of Fanconi syndrome? Fanconi syndrome, Wilson's disease, Wilson's disease, lead poisoning, tyrosinemia, nephrotoxins, multiple myeloma, lead poisoning. Very good. Glycogen storage disease. Not okay. Glycogen storage disease. Okay. Okay. Very well. Very good. Okay. Does everyone feel confident about the renal system? Okay. Does anyone want a break for 10 minutes? Okay, let's take a break for 10 minutes and we can come back at 9:55. Okay.
كتما أبصراب زنبرت مكينو دما بتاعي تهرما تقاتيلا تبل أبعنتا مكينة هاي بومبا متكعتي كم استفدت أمون تقلص أما حبر الميديا استفرقهم بسلطات دما استفر بارن دمن كمون بعرارة تايتي استهرمت مكينة يرئيو أما جمرتا من سبب الخالة تاقر أما نقو حالوتي يتتمراماري متكعتي زفت أمو سباتن هاي تقسم اللوات نيرو كبل مجلسي يبونيرو حدا إيران أو مسكر عينود قبل شبران استبهالو كاب سلسته كساب 4 زقانو سبات تقتلهم يلو مرة خدت مع كانت إيران كأ تمارا ماري فكر زيدا الحقت بتوقع شربرت ويدما الساتلايتيو تقتلو يبلا وصنيخا حالافي ريد مخرج حنا تتهاجر ريد أدميرال شامكاني كل الجباب بمتكام الحقت استفزم مدكعتيو يلو نيرو من سرد حنا إسرائيل إلي كهون مصوني نحد راديو أبزها بوكال من كم زقتلو عين فلتن يلو انت خونا قد نيويورك تايمز هذا العلوي بعد سلطان إسرائيل فكر زيدا زمرك بروجرام نيكلر إيران نعلم سقات سلزخونة علم بإسرائيل كتمسكن اللواء يلو إسرائيل عربيان نتي تمراماري نبار حدا قد بروجرام نيكلر إيراني وإيلهم يأمنو كم تبقى فورميس انت خوينا دما أما خلي مبرق رحوق أتقوى صارم أسوارن نايماشن تريجاتاتن مساتيحو التقمي يوعن سنة سرعة كبري إيران أو تمراماري نيكلر فاكر زيدا تمالي أب تهران تفتيمو جو بايدن مس أخلابو كتواتن كله ودعو كم استقبل تقاليتو حدث تمرس بريزيدنت أمريكا جو بايدن مس أخلابو كتواتن كله ودعو كم استقبل دكتورو أفليتو ودي 78 عام بايدن قدام 18 حدار كلتشن بسران مس أخلابو كتواتن كله كم زودقة استحبر خوينو دحرمو داوخا أبراهو ودعت كم زقات أمو تقاليتو بصباحيتو سنبت كأ أب ديلوير زركب على حكيم عصمتي كم زرعون نايون كحاخمو كيفن أوكنار كأ بريزيدنت بايدن إكسراي تسايلو عصمتو كم تسنتها كاليتو انت دكتور كم زبالو بايدن أبي ماني أقرو كلو تناشتو نايم سنتاق ملكتا ترعينيو زبالو خوينو ترانتو بقلو محرد إلى آخر كاكبن تويتر تحفو بايدن أب تاريخ أمريكا أتي بعد مزعبي بريزيدنت كخون كله دقوا سعيبو تقامتون دقفتون أغلبه يبهم إكاتلوا خمزلو تقاليتو أيوة دكتور قل بايدن نبتعنو يملس الله يدو أبزحل فوحي دكتورو بايدن بريدنت أمريكا خويلو كمرح زخونة تقول لنا قد كم ديلا حبيرو نيرو بايدن تامبل ميجرن تبهالو أخلابات ذلو وخيلو نزل إذو نبيت من استقاعته يحسب كتب أخلابات نيجرمن شيبر استبهاله عليه زلوا كوينو ترامب استبعد خربو وايت هاوس تمكر زنبران بايدن مكتب بريزيدنت اوباما ابزنبران الاوان حاضر وكم زنبران نيجرجن كان مخلط عمل كم تقبلون يجلس كبرى تعذب لون استداروا زيناتنا حافظتنا لنا امود اعتقد اذا كان الحديث تقوم حديث زينا لا تدرينيا فقد من الكبسكم سبسكرايب لجبركم سبسكرايب وخبرنا
Okay, so is everyone back from their break? Do we have everyone who's back from their break? We took quite a long break for 15 minutes. Okay. Okay, good. Okay, so if anyone has joined the lecture a bit late today, you have absolutely nothing worried about. We will be sending you guys the video on our Google Drive. And Okay, of course, we will send the video, no problem. Okay, so with that being said, has everyone who attended the lecture from 8 a.m., have you guys understood the lecture about the renal physiology? Okay. Okay, very well. Let's begin with the next page. Okay, so we're done with this one, that is the potassium shifts. What are the causes of shifting into the cell and what are the causes of the potassium shifts outside the cell? Okay, the next one that we want to talk about is electrolyte disturbances. Okay, so we have 5 major electrolytes. If there's an increased amount of these electrolytes, they will cause a major problems. If we have low amount of these electrolytes, then they will cause major problems. So both of these are very important. Okay, the easiest one to remember is the one about sodium, because the sodium, if we have a low serum sodium level, there is nausea, malaise, stupor, coma, seizures. High serum concentrations will also cause stupor and coma. So the thing is, you are not very widely tested on sodium levels and what are the causes or what are the examples of hyponatremia, because the sign symptoms will overlap with one another. So we can skip out on this one and then move on to potassium. This is high yield. Okay, what happens in low serum concentrations and high serum concentrations of potassium ions? The first thing that you see is a U wave, okay? U wave and a flat T wave on ECG. The way I like to remember U waves for hypokalemia is hypokalemia. Okay. Okay, 1 second. Hypokalemia. If you can remember hypokalemia, then you can easily remember that hypokalemia causes U waves and flattening of the T wave in ECG. If we have hyperkalemia, then there's widening of the QRS and there's peaking of the T waves. So wide QRS and peak T wave on hyperkalemia. We have discussed about this. Do you guys want to discuss about this in details again, or is this information enough? Hypokalemia. Okay, so I guess this information enough. Oh, please discuss. So basically what happens is, okay, let's see what a U wave is and what happens. Okay. Okay. So you see this, this is how an abnormal ECG looks like. And normal ECG would have a QRS, and then a T. Okay, so this, you see this T over here, and then this should be flat. If we have a patient with hypokalemia, then there is conduction abnormality at microscopic levels, for which there is another extra wave over here. This wave is known as U wave. This wave is known as U wave. And another thing that happens in hypokalemia is T wave. So flattening of the T wave. So what is flattening T wave? Flattening of the T wave. This looks like this. You have P, Q, R, S, and then there should have been another bump over here, but there is no bump. There's flattening. And so these are the two things that you can expect to find in a patient with hypokalemia. In hyperkalemia, what we have is we have wide QRS, okay, wide QRS. We talked about this before. I'll talk about this once again. Okay, let's see. Okay. Okay, over here, it's, okay, you cannot see it very clearly. Give me 1 second. Okay. Okay. So this is, so do you guys see how the QRS over here, okay, QRS levels. So we have P, QRS, and then the T segment. Okay, over here, since it's a patient with hyperkalemia, the QRS portions are wider. See the QRS portions over here, these are wider, so wide QRS complex. Another thing that we can expect to find in a patient with hyperkalemia is peaking of the T wave. Over here, if you can see that the T wave over here Let's see if there's any peaking over here. Okay, so there will be, so we have P, Q, R, S, and then there's a small peaking. There's a small peaking of the T wave. This small peaking of the T wave is called peaking or peaked T wave. These are the two things that you find in hyperkalemia. Are we clear? Are we clear on this? Can you guys identify hypokalemia and hyperkalemia? Okay. Next one is calcium. If we have low calcium level, then this is a very high yield. This is very high yield for causing QT prolongations. Other things that can cause QT prolongations are the drugs, that is antiarrhythmic. Then we have antibacterials, antipsychotics, antidepressants, antiemetics, low calcium and low magnesium levels. These are the causes of QT prolongations. So QT prolongations are caused by low calcium level. Even low calcium level can cause tetany and seizures. Okay, there's another sign that is twitching, that is known as the Vostok sign. So basically, if you tap on the cheek muscles, then there will be tightening of the, then there will be twitching of the muscles of the cheek. This is known as Vostok sign. Another one is spasm. Spasm is Trousseau sign. Trousseau sign is when you put a blood pressure cuff, there will be spasms of the forehand muscles. That is known as Trousseau sign. If we have a patient with hypercalcemia, the things that will happen are known as stones, bones, groans, thrones, and psychiatric overtones. We talked about this before. That is stones for renal stones, bones for bone pain, hypercalcemia, why? Okay, hypercalcemia, there will be bone pain, groans for abdominal pain, thrones for urinary frequency, and psychiatric overtones. Okay, over here, the only things that you have to remember are, for the purpose of solving UWorld question, is low serum concentrations for hypokalemia and high potassium concentrations, which can cause wide QRS and T wave. For calcium, you have to remember that calcium causes tetany, calcium causes QT prolongation, and you have to identify a patient with hypercalcemia. If they come and tell you that you have a patient who comes to you let's say the patient is 45 years of age, the patient has bone pain, the patient has bone pain, abdominal discomfort, the patient is depressed or has signs of depression. Okay, so you already have 3 out of 6 findings of hypercalcemia. So please consider hypercalcemia with stones, bones, groans, thrones, and psychiatric overtones. Okay, once again, if I say stones, what do I mean by stones? Can I get some fast answers, please? If I say stones, what does stones mean? Kidney stones. How about bones, bone pain? How about groans? How about groans? Abdominal pain. How about thrones? Thrones for increased urinary frequency. Okay, very good. Psychiatric overtones for anxiety and altered mental status. Okay, anxiety and altered mental status. So if you see these signs symptoms in a patient, then please consider hypercalcemia. Next one is magnesium. Magnesium can also cause tetany. They can cause torsades de pointes. Does everyone remember? Okay, what is torsades de pointes? Torsades de pointes is known as a polymorphic ventricular tachycardia. Okay, so this is, okay, one second. Okay. So you see this thing over here. This is known as a polymorphic ventricular tachycardia. Increase, decrease, increase, decrease again, and then increase. This is known as polymorphic ventricular tachycardia. What is the, why is torsades de pointes and emergency? Why is torsades de pointes and emergency? A medical emergency. Why is this an emergency? Right, very good. Torsades de points can give rise to massive ventricular tachycardia to massive ventricular fibrillation, and then sudden cardiac death. Okay, sudden cardiac death. What you basically have is you have QT prolongation. If you cannot stop QT prolongation, this will proceed to torsades de pointe. Torsades de pointe will proceed to ventricular tachycardia. If you cannot control ventricular tachycardia, then it will move on to massive ventricular fibrillation. If you cannot control ventricular fibrillation, then from over here, patients will have sudden cardiac death. Okay, are we clear on the process of how QT prolongation can cause sudden cardiac death? All the steps? Okay, good. So tetany can also cause torsades de pointe. Tetany can cause, magnesium can cause torsades de pointe. There can also be hypocalcemia, hypocalcemia. Along with that, magnesium is also known for causing decreased deep tendon reflexes. This is high yield for USMLE step 1. You'll be tested on this in UWorld, so please put a star over here. Okay, that magnesium causes decreased deep tendon reflexes. They also cause lethargy, bradycardia, hypotension, cardiac arrest. Over here, cardiac arrest, we already talked about this, how they can cause sudden cardiac death, so cardiac arrest. Phosphate can cause bone loss. If we have low serum concentrations, they can cause bone loss because phosphate is a major component of osteogenesis. They can cause osteomalacia in adults and rickets in children. On the other hand, if there's a high phosphate content can cause renal stones, metastatic calcifications, and hypocalcemia. These are the three things. The highest yield serum electrolyte that is important for your USMLE step 1 is potassium, and after potassium, it's calcium. These are the two high yield, and you will receive a massive amount of questions from potassium and calcium. That's it. Okay. Are we clear on this? Are we clear on the serum electrolyte levels? Okay, good. Okay. The next is we want to talk about the features of renal disorders. We want to talk about the features of renal disorders. Okay. Before we do that, before we jump into the text in first aid, okay, there are some things that I want to talk about. Okay, there are some things that I want to talk about. First of all, what I want to do is I want to talk about these things by ourselves, and then we can move forward. Okay, so just give me 1 second that I draw this table out. Okay. Okay. So this is the table for blood pressure. This is the table for renin, aldosterone, magnesium, and urine calcium. Calcium in the urine. Okay. Number one condition is syndrome of inappropriate anti-diuretic hormone. In syndrome of inappropriate anti-diuretic hormone, if we have a high amount of ADH, for example, the number one cause of syndrome of inappropriate anti-diuretic hormone is ectopic ADH production. Can you guys tell me one high paraneoplastic syndrome or paraneoplastic tumor which can release ADH? Small cell lung carcinoma, very good. Cell lung carcinoma. Small cell lung carcinoma is responsible for ectopic ADH production. If we have high amount of ectopic ADH, will there, okay, first of all, before we move on, I have a question from Dr. Nadine. Is random ECG reading required in step 1? Not a lot, but there are some ECG readings which are high yield, and we will discuss about this. We will discuss these ECG readings before your exam, so you have nothing to be worried about. We will cover everything. Okay, with that being said, let's move back to our lectures. First of all, my question was which can secrete a high amount of ADH, and you guys have mentioned small cell lung carcinoma, and that is the correct answer. Can you guys tell me another drug that can cause SIADH? A very high yield drug which can cause SIADH? Carbamazepine. All right, very good. So these are the drugs that can cause SIADH and ectopic, I mean your small cell lung carcinoma. So if you have a high amount of ADH, this will obviously increase. Okay, this will obviously increase your blood pressure because ADH will increase the blood volume. They will cause increased water reabsorption, and this will increase the blood volume. If the blood pressure increases, okay, first of all, can I have the students unmute themselves so that I can finish this fast? I can go back to the chat box and keep on seeing back and back. Okay, so you guys are at liberty to unmute yourself and answer the questions. If you guys have increased amount of blood pressure, what would happen to the renin? Lower high? Decrease. Very good. If renin decreases, what happens to aldosterone?
Decrease.
Very good. Okay, aldosterone decreases. Not a lot of change happens in magnesium and urinary calcium. Okay, not a lot of change happens in these two things. Good, very good. Next one is if we have a patient with hyperaldosteronism, primary hyperaldosteronism. For example, let's say we have an adrenal gland tumor. So primary hyperaldosteronism. If we have high amount of aldosterone, what happens to the blood pressure? Will there be increased water reabsorption?
Increase.
Of course, the blood pressure will increase.
Increase,
Will
yeah.
increase the water reabsorption. So blood pressure will increase. If blood pressure increases, once again, what happens to renin?
Decrease.
Renin will decrease. Aldosterone itself
Increase.
is, since there is primary hyperaldosteronism, aldosterone is increased. So the thing is, whenever you receive a question next time, low renin and high aldosterone. Okay, this is highly unlikely in a normal patient because in a normal patient, if renin is low, aldosterone should be low too. So if you have a patient with low renin and high aldosterone, this means that the negative feedback mechanism from aldosterone to renin is not working. That must mean 100% that the patient could have an adrenal gland tumor, primary hyperaldosteronism. With that being said, once again, magnesium and calcium are not that highly affected. Next one is if we have a reninoma. Reninoma. Have you guys heard of a reninoma? Yes or no?
Yes.
Okay. Reninoma. Reninoma basically means the tumors of the renin. Okay. So if we have increased amount of renin due to reninoma, what happens to the aldosterone level?
Increase.
Aldosterone is increased. What happens to blood pressure?
Increase.
Very good.
Yes.
Okay. Next one is I want to talk about renal tubular defect or salt-losing nephropathy, that is Bartter syndrome. Okay. What happens in Bartter syndrome? Bartter syndrome, do you guys remember what happens in Bartter syndrome?
Loop of Henle.
Okay. If we have Bartter syndrome, do we have loss of salt and water?
Yes.
Okay. Because salt is being lost because the salt losing nephropathy. If we have decreased salt and water or decreased water reabsorption, what happens to the blood pressure?
Decrease.
Blood pressure will decrease. What happens to renin?
Increase.
What happens to aldosterone?
Increase.
Okay. Can we say that this is the same thing that can happen for Gitelman syndrome? Yes or no?
Yes.
Same thing, right?
Yes.
Loss of water. As a result, renin will increase, aldosterone will increase. Okay. Aldosterone will increase. But the thing is, Gitelman syndrome and Bartter syndrome, I want to talk about the magnesium and the calcium level. What is the location of the Bartter syndrome and what is the location of the Gitelman syndrome?
Bartter is ascending loop. Gitelman is distal convoluted tubule.
Okay, what did the baby say? Did the baby say limb of loop of Henle? Okay, if he said that, then that should be true. So Bartter syndrome, if it's working on the thick ascending limb of loop of Henle, then what happens to the calcium level, serum calcium level? If
it will decrease.
Calcium
okay, serum calcium level decreases, then what happens to the urinary calcium level?
Increases.
Increase.
Very good. Okay, so urinary calcium level will increase. We talked about it before, how Bartter syndrome can cause hypercalciuria and hypocalcemia. Next one is Gittleman syndrome. Gittleman syndrome, what is the location of Gittleman syndrome?
Distal convoluted.
Very good. Distal convoluted tubule. In distal convoluted tubule, if we have decreased activity of the channels, what happens to the serum calcium level? Is it increased or decreased? Calcium is increased. Serum calcium is increased. What happens to the urinary calcium level?
Decrease.
Urinary
Decrease.
calcium decrease.
Urinary calcium is decreased.
Decrease.
Calcium is increased. Okay, next one. Next one is if we have a patient with SAM, syndrome of apparent mineralocorticoid excess. What happens to the blood pressure if the mineralocorticoid is increased?
Increase.
Increase.
If blood pressure is increased due to mineralocorticoid, what happens to the renin level?
Decrease.
Increase.
Okay. Syndrome of apparent mineralocorticoid excess. Is it due to cortisol or aldosterone?
Cortisol.
Cortisol.
Very good. So what happens to the aldosterone level?
Decreased.
Decrease.
Decrease.
Okay. Okay. So that's exactly what it is. So these are the things that you guys have said. First of all, let me thank you for participating actively. For all the students who has participated actively, thank you so much. And having said that, have you guys understood the changes over here? Yes or no? Have you guys understood the changes? Okay, do we have any confusion? Have any confusion? Okay, good. So no confusion, let's move forward. Okay, let's move forward. Okay, now we have come to a very high yield piece of physiology. We are done with the features of the renal disorders. We're done with the features of renal disorders. The next one that we're going to go to is acid-base physiology. Next one that we're going to go to is acid-base physiology. And once again, you guys will help me out in figuring out what's going on over here, okay? Figuring out what's going on over here. But before I ask you guys the question, there is something that I want to discuss. Okay, there's something that I want to discuss. Okay, so first of all, before I want to discuss this, I want to give you guys the liberty of unmuting yourself and asking me questions because I really want to finish this. Okay, I really want to finish this. Before we do that, okay, Dr. How will the questions come? Questions, how will it come from the features of renal disorder is that they will come exactly like in a table format, up, down arrows, and you have to figure out which condition will cause up and down of which of the segments. Are we clear in UWorld? Okay, so I did not put any star over there. The only reason I did that is because everything from that table is extremely important. Everything. There's not a single particular thing that I can say that is less important than the other one. Always remember that the things that I discuss in the blank pages, these things are extremely important. Okay. Okay. So with that being said, you guys are once again at liberty to unmute yourselves and ask me questions if you guys have any questions. But please ask me questions when I ask you if you have any questions. Okay. Other than that, let's move forward. So the thing is, first of all, what we want to do is we want to diagnose a patient with an acid-base anomaly. My first question to you guys is, if you guys are the attending physician, if you guys are a physician and you want to diagnose an acid-base disorder, what test are you going to do in order to diagnose a patient with acid-base disorder? Anyone?
Bicarb.
Arterial blood gas.
Very good. ABG. Very good. What you are going to do is, if you want to diagnose a patient with an acid-base disorder, you want to test for ABG. ABG stands for arterial blood gas analysis. Arterial blood gas analysis, which will tell you about the pH, hydrogen bicarbonate, and all the other things. Okay, so First of all, you want to check the arterial pH. Before we do that, what is the normal pH of the blood? Everyone? What is the normal pH of the blood?
7.35 to 7.5.
7.4.
7.35 to 7.4. This is the
4.5.
if we have, okay, right now, we want to diagnose, we want to diagnose an acid-base problem. Okay, if we have a patient who has less than 7.35, is this acidosis or alkalosis?
Acidosis. Acidosis.
Do we have?
Acidosis.
How many types of acidosis do we have?
Two.
Metabolic and
Respiratory.
Okay, good. Very good. So we have metabolic and respiratory acidosis. Let's talk about acidosis first. Okay, acidosis. First of all, you said that we have respiratory acidosis, and then we have
Metabolic.
okay, if we have any surrounding sounds, could you please ask the student to decrease the sound so that we can concentrate a little? Thank you so much. Okay, so respiratory acidosis and metabolic acidosis. Okay, first of all, respiratory acidosis. Acidosis in respiratory system, meaning that the partial pressure of carbon dioxide or PCO2, is this increased or decreased?
Increased.
Okay, respiratory acidosis is increased. If we have PCO2, which is increased during ventilation, when we exhale, do we release carbon dioxide or oxygen? Very easy science question.
Yes.
Carbon dioxide.
Okay, so obviously in a patient who has increase in partial pressure of carbon dioxide, in these patients, there is low amount of ventilation, correct? Hypoventilation. Are we correct? Okay.
Yes.
So now the thing is, we have to talk about the causes of hypoventilation. Why is the patient hypoventilating? Okay, this is our primary concern. First of all, if we think about the lung in general, okay, if we think about the lungs in general, for lungs to hypoventilate, there could be some problem. First problem is there could be air that is coming out. There can be an obstruction over here, right? There could be an airway obstruction. For example, let's say let's say a piece of food gets stuck over here, then this will obstruct the airflow. If it does, will the patient hypoventilate? Yes or no?
Yes.
Okay, number one. Number two is if we have inflammation of the lungs, such as pneumonia. If we have an acute lung disease, such as pneumonia, will this cause decreased movement of the lungs? Yes or no? Or decreased functioning of the lungs? Yes or no?
Yes.
If we have
Decreased function.
of the lungs, the patients will have hypoventilation. That's number two. Number three, if we have a patient with chronic obstructive pulmonary disease or chronic lung diseases, since it's a chronic inflammatory disease, there will be fibrosis. And if there is fibrosis, then there will be decreased movement of the lungs. Yes or no?
Yes.
Yeah.
Yes.
Very good. So that's number three. Number four is if we have, let's say, morphine or sedatives, can they cause respiratory depression, respiratory depression in the brain?
Yeah.
Okay. So that is your number four cause. Okay. And the last one is we have this piece of muscle over here. Okay. This very important piece of muscle. What is the name of this muscle?
Diaphragm.
If we have a patient with myasthenia gravis and it affects the diaphragm, will there be decreased movement or increased movement of the diaphragm?
Decrease.
Decreased. If there's decreased movement of the diaphragm, will this cause hypoventilation or hyperventilation?
Hypoventilation.
So what are the causes of hypoventilation? Number one, airway obstruction. Number two, acute lung disease. Number three, chronic lung disease.
Obstructive.
Number four, opioids,
Morphine.
morphine, sedatives. Number five is
Diaphragm
weakness of the
paralysis.
respiratory muscle or myasthenia gravis or some sort of a muscular problem. Are we clear?
Yes.
Okay. Are we clear? Okay, good. Okay. Then the next one is metabolic acidosis. Okay, what is metabolic acidosis? Metabolic acidosis is basically a condition in which the pH of the blood is less than 7.35 due to increased amount of hydrogen. Okay, so over here, the main concern is hydrogen, increased hydrogen or decreased bicarbonate. Yes, am I correct or did I write something incorrect?
Correct.
Correct.
Okay, we're correct. Okay. Now, the thing is, before we diagnose the patient with metabolic acidosis, we have to check another very high yield thing. What is the high yield thing that you have to check? The high yield thing that you
Anion gap.
Ag or anion gap. What is anion gap? Anion gap is basically how in your blood you have sodium, potassium, chloride, bicarbonate. Are these not the major electrolytes in the blood? Yes or no?
Yes, they are.
Yes.
We have calcium, we have phosphate, and those are really important, but these are very important because they maintain the cellular homeostasis. What is anion gap? Anion gap is basically all the positives. So let's say sodium and potassium, they're the positives. You add them and you subtract the negative ions, that is the anions, that is chloride and bicarbonate. Okay. The normal anion gap, what is the normal anion gap? The normal anion gap is basically around 8 to 12 milli equivalent per liter. If we'd have a patient with arterial pH less than 7.35, and the anion gap is between 8 to 12, then that patient has normal anion gap metabolic acidosis. Okay, so let's talk about our normal and then we will talk about abnormal. So let's say anion gap, we calculate it, it's 8 to 12. Okay, it's 8 to 12. Now the patient has a normal anion gap metabolic acidosis. What also happens in normal anion gap metabolic acidosis is that the patient does not lose out on any, more or less, it does not lose out on any ions. If the patient lost out on excessive ions, let's say the patient lost a lot of chloride, the patient has increased formation of chloride or anything else, then then there could be your problems with the anion gap. Now, over here, the homeostatic level is being maintained. Okay, so what are the causes of anion gap? First of all, okay, what first aid uses is a mnemonic that we also like to use. Okay, studying acid-base disorder. Okay, it's a hard ass job. Okay, hard ass is basically a slang word. Okay, hard ass, it's a slang word. It's a very hard ass job to study the acid-base disorders. Hard ass, H4, hyperchloremia, or hyperalimentation. What is hyperalimentation? If we have a patient on total parenteral nutrition, and if that alimentation, if we do that for a long period of time, the patients can get hyperchloremia. So that is hyperalimentation. Next one is Addison's disease. What is Addison's disease? Who remembers Addison's disease?
Primary adrenal insufficiency.
Very good. If we have a patient with Addison's disease, what happens in Addison's disease regarding the metabolic acidosis?
Excuse me, doctor.
Yes.
Someone is waiting.
Oh, someone is waiting. Okay.
Thank you.
Thank you. Okay. If we have a patient with Addison's disease, that is primary adrenal insufficiency. Okay. And will there be decreased amount of aldosterone or increased amount of aldosterone?
Decreased.
If aldosterone is decreased, what happens to the hydrogen level? Is it less secreted or more secreted?
Less secreted.
Less secreted.
As a result?
Metabolic acidosis.
Metabolic acidosis.
Addison's disease. Next one is renal tubular acidosis. We have not studied renal tubular acidosis. We will study them in 1 second. So we will keep this now and we will take this explanation and make you understand a bit later. Okay. But try to remember R for renal tubular acidosis. Next one is D for diarrhea. If we have diarrhea, is there an increased loss of intestinal bicarbonate? Yes or no?
Yes.
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 If bicarbonate decreases, although the cellular homeostatic level is still maintained, so the patients have metabolic acidosis. Next one is acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor. Carbonic anhydrase inhibitors, if we have decreased amount of carbonic acid formation, then there is decreased amount of hydrogen ion formation and bicarbonate ion formation. If there is decreased amount of hydrogen and bicarbonate ion formation, then decreased amount of hydrogen is being released or secreted. As a result, the hydrogen in the blood, it accumulates. Okay, so acetazolamide. S for spironolactone. Spironolactone is once again a potassium sparing diuretic, which can cause metabolic acidosis to some extent. And the last one is saline infusion. So that's that. So hard as, once again, H4, hyperkalemia, Addison's disease, renal tubular acidosis, D for diarrhea, A for acetozolamide, S for spironolactone, and S for saline infusion. Are we clear on this, the normal and gap? Yes or no?
Yes.
Okay. Next one. Next one is if we have a patient with high anion gap, let's say more than 12, then we have to consider some other diseases. These diseases are known as high anion gap metabolic acidosis. What are the causes of high anion gap metabolic acidosis? And the mnemonic that we will use for this one is known as mud piles. Mud piles. Okay. Mud piles. M for methanol. Methanol. Okay. U for uremia. If we have increased amount of if you have increased amount of urea, okay, then this can cause high amount of non-gap metabolic acidosis. Next one is diabetic ketoacidosis, where there's active formation of the hydrogen ions. Okay, and then the next one is P for propylene glycol. Propylene glycol is antifreeze. Okay, this is basically this can be abused by young children
Yeah.
because propylene glycol, they look like a blue drink, which they think are soft drinks. So they might have it by mistake and cause, and they can have metabolic acidosis. They can have high and non-gap metabolic acidosis. Next one is iron tablets. I for iron tablets. Iron tablets can also cause metabolic acidosis. L for lactic acidosis. E for ethylene glycol, and S for salicylate. That is, if you have a patient with salicylate poisoning, there's an early stage and a late stage, and in the late stage we have high and non-gap metabolic acidosis. Okay, so the thing is, before I jump on to alkalosis, what I need you guys to do is let's go back to our text. Let's go back to our text over here. I need you guys to read this for 2 minutes. Please read this for 2 minutes, and then I will ask you guys 3 physicians to help me out by performing an active participation. Okay, because the reason is we would like to do the revision, recapitulation, and review of the text in first aid right now, because we want to use the rest of our days doing UWorld questions. So whatever reading and understanding and memorizing you have to do regarding first aid, you have to do it right now. Okay. Normal saline contains hydrogen ions. Are we clear? Normal saline, high amount of saline contains hydrogen ions. So extra hydrogen ions can cause normal anion gap metabolic acidosis. Are we clear? Are we clear? Okay. So 2 minutes, after 2 minutes, it's 10:38 right now. At 10:40, I will ask you guys the question. Please, I would need the help of 3 physicians who can confidently tell me the causes of the acidosis. Okay, so 2 minutes on the clock. Let's go. Okay, is anyone done? Is anyone done with the causes? Very good. We have 1 student. We need the help of 2 more students. Is anyone else done? Okay, another one. Okay, very good. Okay, so let's begin with Dr. Hussein. Okay, so
October 1st. October 1st.
okay, Dr. Hussein,
Yeah.
our love and prayers
Oh,
for your little baby. Okay,
yeah, sorry.
if we have a patient with respiratory acidosis, what are the causes of acidosis?
Respiratory acidosis, airway obstruction, um, acute lung disease,
Very good.
COPD,
CEO.
um,
Next one.
drugs زي الأوبيويد and sedative, and myasthenia gravis or weakness, muscle.
Muscle. Thank you so
Yeah.
much. And thank you so
Okay.
much for
Thank you.
completing USMLE Step 1 while being a full-time mother. Okay, so all the best to you. And thank you so much. Let's move on to our next student, that is Dr. Mohammed. Dr.
Yes,
Mohammed,
doctor.
would you be kind enough to tell us what is the normal anion gap?
It's hardest mnemonic. We start with the hyperchloremia, then
Okay,
Addison disease.
hyperkalemia.
A it's for Addison disease. R for renal acidosis.
Very good.
D diarrhea. A
Diarrhea.
is acetazolamide. S
Acidozolamide.
for spironolactone and S for saline.
Very good. Absolutely wonderful. Okay, next one.
Okay.
Next one is we have a new student, that is Dr. Fagan. Dr. Fagan, would you be kind enough to tell us what are the causes of increased anion gap?
Decreased anion gap, that would
Increased
be
anion
increased anion gap.
Right, correct.
That would be your mud piles,
Very good.
methanol.
Methanol.
U is for uremia.
Uremia. D4.
D for diabetic ketoacidosis.
Ketoacidosis. P4.
P for that's
Propylene glycol.
propylene glycol.
Very good.
I for iron tablets.
Very good.
L
L4.
for lactic acidosis.
Lactic acidosis. E4.
Ethylene glycol
Ethylene glycol. Wonderful. And the last one is
for salicylates in the late stage.
salicylates in the late phase of salicylate poisoning. Thank you so much for performing. We really appreciate your participation. The next one is Dr. Mridula. Would you be kind enough to tell us what is the normal anion gap of the
8 to 12.
Very good, 8 to 12. Okay. Next one is Dr. Naud. Thank you, Dr. Mridula. Dr. Naud, would you be kind enough to tell us what is the normal pH of the blood?
Normal pH of the blood is between 7.35 up to 7.45.
Perfect. Thank you so much. Okay, so that's what it is. Okay.
Doctor, you have muted yourself.
Oh, my apologies. Okay, so there's another thing that I want to discuss. So first of all, thank you so much to all the students who participated actively. And with that being said, before I move on to the next topic, that is alkalosis, okay, what I want you guys to understand is in respiratory acidosis and metabolic acidosis, you have changes in pH, you have changes in partial pressure of carbon dioxide, and you have changes in bicarbonate ions. Okay, so so let's say in partial pressure of carbon dioxide, if it's more than 44, it causes respiratory acidosis. And in metabolic acidosis, if the bicarbonate level is less than 20, then it can cause metabolic acidosis. But I do not expect you guys to keep this in mind. The reason for which I'm going to tell you this right now is because in your actual exam, you will have a labs portion in your simulator. So if you are ever confused if the patient has acidosis or alkalosis, just click on the normal lab values. Over there, you will have the normal levels of partial pressure of carbon dioxide and the normal levels of bicarbonate. And you can match the patient's scenario and match the patient's electrolyte level to the normal levels. If they are decreased, then that means it's acidosis. If it's increased, that means it's alkalosis for bicarbonate, and vice versa for partial pressure of carbon dioxide. So please stay away from trying to understand, trying to remember or memorize the levels of these things. Just use the simulator, which is there in your actual exam. They will have the normal lab values. You also have them in UWorld, and you can use them to answer your questions. Okay. With that being said, let's move on to the next group of disorders. Okay, so what I want to discuss right now is respiratory and metabolic alkalosis. Once again, if the normal pH of the blood is 7.35 to 7.45, then alkalosis is the condition in which the pH of the alkalosis is the condition in which the pH of the blood is more than 7.45. Okay, now we will discuss about the causes. First of all, metabolic alkalosis. Once again, you are at liberty to unmute yourself and answer any questions. Okay. First of all, how many types of how many types of alkalosis do we have? Easy question.
Respiratory and metabolic.
Very good. Right now, if we have respiratory alkalosis, what do we expect the partial pressure of carbon dioxide to be? High or low?
Low.
Low.
Low partial pressure of carbon dioxide. Okay. If we have low partial pressure of carbon dioxide, does that mean the patient is exhaling more air? Yes or no?
Yes.
Yes.
Hyperventilation.
Yes.
If the patient
Hyperventilation.
very good. If the patient has to have increased amount of exhalation, that means the patient is hyperventilating. So the causes of respiratory alkalosis is the exact opposite of acidosis. That is, the patient is hyperventilating. Okay, so hyperventilation patient. Now, what we will talk about are the causes of hyperventilation. Number one, if you have a panic attack, or you're anxious about something, do you have fast breathing or slow breathing?
Fast.
Fast.
Fast breathing. So the number one cause is anxiety. Okay, number one cause is anxiety or panic attacks. Okay, next one. If you go to a high altitude, let's say on top of a mountain, do you have decreased amount of oxygen, partial pressure of oxygen, or increased amount of partial pressure of oxygen?
Decrease.
If you have decreased PO2, will you hyperventilate or hypoventilate?
Hyper.
So
Hyperventilation.
very good. So next one is high altitude or decreased partial pressure of oxygen. Number three, if you have a salicylate poisoning, in the early stages, what you have is hyperventilation. In the late stages of salicylate poisoning, you have metabolic acidosis. But in the early stages, you have hyperventilation because it affects the brainstem, the salicylate. So it affects the brainstem and it stimulates the brainstem and it causes contraction of the diaphragm and the the patient starts hyperventilating. So the next one is salicylate. That is the early stage of salicylate poisoning. Okay. Another one. If we have a tumor, okay. Tumors, what they cause is if we have tumors of the lungs, okay, obviously the lungs will get decreased amount of oxygen. The patient will be in a hypoxic state. Yes or no?
Yes.
Yes.
If a patient is in a state of hypoxia, will this increase the ventilation or decrease the ventilation?
Increase.
Increase the ventilation because your body will try to ventilate more to increase the partial pressure of oxygen. So tumor. Next one is the same. That is pulmonary embolism. In pulmonary embolism, okay,
Hyperventilation.
patients will also have hypoxia, and as a result, they will try to hyperventilate. So these are the 5 causes of hyperventilations: anxiety, high altitude, early stage of salicylate poisoning, tumor, and pulmonary embolism. Next one.
Doctor, you mean tumor because it take place in the lung?
Yes. Okay.
So less respiration, you mean?
Right. Okay, next one. Next one is metabolic alkalosis. What happens in metabolic alkalosis? In metabolic alkalosis, you have, once again, what do you have in metabolic alkalosis? Either hydrogen is decreased and bicarbonate is increased. Am I correct? Yes or no?
Yes.
Yeah.
Okay, good. The main concern is bicarbonate. Okay, because this can easily be disturbed. High hydrogen, to be honest, is not that disturbed. So bicarbonate is our main concern. If we give a patient loop diuretics, that is, let's say the sodium potassium 2 chloride channel and the thick ascending limb of loop of Henle, if this is blocked, will the patients have metabolic acidosis or alkalosis? We have discussed this before.
Alkalosis.
Alkalosis.
Are you guys clear on that note? How does loop diuretic cause metabolic alkalosis? Yes or no?
Because potassium losing, because of potassium losing, and
Okay, okay. 1 second. If we have a patient with loop diuretics, what happens to the blood pressure? Is it decreased or increased?
Decrease.
decrease.
If you have increased blood pressure, is there high amount of activity of renin-angiotensin aldosterone?
Yes.
Yes.
If there is high amount of angiotensin, can it activate the sodium hydrogen exchanger
Yes.
in the proximal convoluted tubule and cause contraction alkalosis? Yes or no?
Yes.
Yes.
As a result, can that cause metabolic alkalosis? Are we
Yes.
clear on this now? Does everyone understand how loop diuretics cause metabolic alkalosis, or do I repeat myself once again?
Because of angiotensin loss system, yes.
Exactly. Angiotensin
Because of
works in the
compensation.
proximal convoluted tubule and causes contraction alkalosis by activating the sodium hydrogen exchanger. Increased amount of hydrogen is lost in the urine. As a result, patients are in a state of metabolic alkalosis. Are we clear?
Yes, but doctor, can you repeat about spironolactone, so how it causes acidosis?
Okay, we will go back to spironolactone, how it causes acidosis. Before we do that, let's finish metabolic alkalosis. Are we clear how loop diuretics causes metabolic alkalosis? Yes or no?
Yes.
Okay, loop diuretics are your number one. Along with loop diuretics, can I also say that all the other types of diuretics can cause metabolic alkalosis? Yes or no?
Yes.
No.
Because no matter what, if there's decreased amount of blood volume, I mean, if there's increased amount of blood volume, okay, I mean, if the amount of urine is increased, then blood volume is decreased. If blood volume is decreased, increased activation of renin-angiotensin aldosterone system and increased amount of angiotensin 2 that is formed in renin-angiotensin aldosterone will activate the sodium hydrogen exchanger in the proximal convoluted tubule, and high amount of hydrogen will be lost in the urine. So loop diuretics and most of the other types of diuretics can cause metabolic alkalosis. Okay, next one. Next one is if we have a patient who is actively vomiting patient, will they lose hydrochloric acid or gain hydrochloric acid?
Lose.
Lose.
If you lose hydrochloric acid, you have decreased amount of hydrogen, you have metabolic alkalosis. Next one is antacid. Next one is antacid. If we have a patient who's having antacids work against the acid, okay? They neutralize the acid, they put the whole body, I mean, they disrupt the whole body into an alkalotic pH. So antacids are your number three. Number four is hyperaldosteronism. If we have a patient with hyperaldosteronism, how can this cause metabolic alkalosis? I need some fast.
Hydrogen loss.
Increase.
Hypokalemia, doctor. How hypokalemia will lead to alkalosis?
Loss
Right.
of hydrogen.
Hyperaldosteronism. Can this activate the channel in the alpha intercalated cells?
Yeah.
Yes.
And cause increased loss of hydrogen? Yes or no?
Yes.
Okay.
Yes.
So as a result, if we have increased loss of hydrogen, can this cause metabolic alkalosis?
Yeah.
Yes.
Okay. So that is your reason. Okay. Once again, we will need you guys to take 2 minutes. Okay. And a group of new students are needed to participate in order to tell me the causes of respiratory and metabolic alkalosis. I will need the help of at least two students. At least two students, okay? Thank you so much for participating in active participation. That's that, okay? So I will give you guys 2 minutes, 10:54 as of right now. At okay, 10:54. And at 10:56, I will ask you, please tell me if you're ready to answer the questions.
Doctor, I have a question before.
Okay, what is your question?
What is the difference between salicylates early and late?
Okay, so what happens is in the early stage of salicylate poisoning, it goes and it affects the brainstem and it activates the brainstem. The brainstem has a respiratory center. If it gets activated, then there's increased amount of ventilation. So this causes hyperventilation. In the late stages, it does not affect the brainstem anymore. In the late stages, what this does is this causes disruptions of the channels of the membrane channels. And as a result, what happens is this causes an electrolyte imbalance. increases the anion gap and causes metabolic acidosis. That's what happens in salicylate poisoning. Okay.
Thank you.
Okay. So 2 minutes on the clock. One more minute. Just try to remember the causes of respiratory and metabolic alkalosis, and I will need the help of two more students. Okay, we have one physician who is already ready, Dr. Iman. Thank you so much. Anyone else? Okay. So we have a question from Dr. Nadeem that is, okay, I do not understand the changes of bicarbonate in respiratory acidosis and alkalosis. Okay, bicarbonate is not changed in respiratory acidosis and alkalosis. Bicarbonate changing is responsible for causing the problems in metabolic acidosis and metabolic alkalosis. The main things to look out for in respiratory system is partial pressure of carbon dioxide. Increased amount of partial pressure of carbon dioxide will cause respiratory acidosis. Decreased amount of partial pressure of carbon dioxide will cause respiratory alkalosis. Are we clear? We do not measure bicarbonate level for respiratory acidosis or alkalosis. Okay? Are we clear on this? Okay, let's move on. Let's go to Dr. Iman, who wants to participate. So, Dr. Iman, would you be kind enough to tell us what are the causes of respiratory alkalosis?
Hyperventilation,
Hyperventilation, and what are the
like
causes of hyperventilation?
panic attack or
And
anxiety,
okay, then
salicylate in
early salicylate poisoning, two more,
pulmonary embolism,
pulmonary embolism,
and tumor.
tumor. Thank you so much for participating. Next one. Next one is next one. Next one is wait 1 second. Next one is Dr. Mirdula. Would you be kind enough to tell us what are the causes of metabolic alkalosis?
It is those are due to hydrogen ion loss,
Mm-hmm.
low diuretics,
Mm-hmm.
vomiting, antacid use, and hyperaldosteronism.
Okay, very good. Okay. Thank you so much for participating. Let's go back to Dr. Nadeem. Okay, but in the table it says increased and decreased. Okay, let's see which table you're talking about in first aid. Okay. So which table are we talking about here? If you diagnose a patient with the respiratory acidosis or respiratory alkalosis, you have to measure only the partial pressure of carbon dioxide. Okay, partial pressure of carbon dioxide. The only reason if you have to measure the bicarbonate ion level in respiratory acid-base disorder is to see that if there has been proper compensation for the respiratory problems or not. Okay. Having said that, okay. Oh, which table? This table. Oh, this table. Oh, this table. We have not come to this table yet. We will come to this. We have not come to this table as of yet. We will come to this. Okay. Okay. Dr. Nadeem, we have not come to that table because I knew this table is a bit confusing. So I wanted to make you guys understand what the acidosis and alkalosis is. And now that we have understood successfully, now we can go to the table, which Dr. Nadeem is talking about. This one. Okay. So once again, what happens is in respiratory acid-base disorder, the only thing that you have to measure first is the partial pressure of carbon dioxide. After that, that's the only way you can diagnose a respiratory acid-base problem. And then we also measure the bicarbonate level to see if there has been proper compensation or not right now. Okay, the same goes for in metabolic acidosis and alkalosis. We measure the pH, hydrogen and bicarbonate level. We also measure the partial pressure of carbon dioxide, not for diagnosing the metabolic acid-base problem, We measure them to see if there has been proper respiratory compensation or not. Okay. Okay. Having said that, what is compensation? Before we move on to compensation, I want to talk about compensation. Okay. Okay. So the first thing that I want to talk about is the first thing I want to talk about is okay. So can I get you guys to unmute yourselves and answer me questions, please? Because this will help me finish the topic faster. First thing that I want to talk about is acid-base disorder and compensation. Okay. Can you guys hear my voice? Have you guys unmuted yourselves?
Yes.
Very good. Okay. First thing is if we have a patient, okay, if we have a patient with metabolic acidosis, if you have a patient with metabolic acidosis, okay, over here, metabolic acidosis, we already have metabolic acidosis, that is the hydrogen ion is increased and bicarbonate is decreased. pH is also decreased. Okay. Okay. The main problem with hydrogen and the increased hydrogen and decreased bicarbonate is with metabolic acidosis, the compensatory response, is it by the renal system or by the respiratory system?
Respiratory system.
Respiratory.
Respiratory system.
Okay, why is there respiratory compensation for metabolic acidosis? Because if we want to compensate metabolic acidosis, the primary cause for decreased bicarbonate could be
Renal.
the system itself. Could be the renal system itself. So it's almost quite impossible, if not, to correct the metabolic acidosis by the renal compensation mechanism, because the main problem could be the renal problems for which the patients have metabolic acidosis. So the respiratory system has to take over. Right now, if we have a patient with increased amount of hydrogen and decreased pH, do you want to have more partial pressure of carbon dioxide or less partial pressure of carbon dioxide in your lungs?
Less.
Less.
Why? Why? My question is why? If you have more partial pressure of carbon dioxide, then that carbon dioxide will bind with water to form carbonic acid
Bicarbonate.
and hydrase, and then form hydrogen, more hydrogen, right? And that more hydrogen will cause more problems. So
More acid.
So what we want is we want to have low partial pressure. What we want to have is we want to decrease the partial pressure of carbon dioxide. So if you want to decrease the partial pressure of carbon dioxide, do you want to hypoventilate or hyperventilate?
Hyperventilate.
Exactly. If you hyperventilate, then the excess carbon dioxide will get exhaled and the patients will have compensation. Okay, so the excess partial pressure of carbon dioxide will get exhaled. Okay, so this is the reason why in metabolic acidosis you have pH that is decreased, then partial pressure of carbon dioxide that is decreased, and bicarbonate that is also decreased.
Decrease.
Are we clear on this? Yes or no?
Yeah. Yeah.
Next one I want to talk about is metabolic alkalosis. In metabolic alkalosis, what happens with the pH? pH is increased.
Increase. Yeah.
pH is increased. And what happens to the bicarbonate ion? Bicarbonate ion in metabolic alkalosis is obviously increased, right? Right now, in this patient, if you want to compensate, will you compensate via the renal mechanism or the respiratory mechanism?
Respiratory.
Respiratory mechanism. If you have to compensate by the respiratory mechanism, do you want to keep more carbon dioxide or less carbon dioxide?
More carbon.
More.
Very good. You want to increase the partial pressure. How do you increase partial pressure of carbon dioxide? By hyperventilation?
Hypoventilation.
Hypo.
So this is what happens in metabolic alkalosis. Okay, good. Next one is respiratory acidosis. In respiratory acidosis, what is the primary problem? Bicarbonate or partial pressure of carbon dioxide?
Carbon dioxide.
Partial pressure of carbon dioxide is the primary problem. Partial pressure of carbon dioxide is the primary problem. So in respiratory acidosis, what we have is partial pressure of carbon dioxide that is increased. Respiratory acidosis, partial pressure of carbon dioxide is increased. Why? Because do you guys remember? Because of the hyperventilation causes, for example, airway obstruction, acute lung disease, chronic lung disease, right? Weak respiratory muscle, right? Those are the causes of acidosis. And then opioids, right? So the partial pressure of carbon dioxide is increased. Now, if the respiratory problem is the main problem, do you want to compensate via the respiratory system that is the problem, or do you want to compensate via the renal system?
Renal
Renal.
So if pH is increased, that means the hydrogen ion is also increased. So in respiratory acidosis, pH is decreased, hydrogen is increased. So do you want to increase bicarbonate or decrease bicarbonate?
Increase.
Increase bicarbonate.
Increase.
Decrease.
It is decreased. We want to increase it.
No, we want to
Okay, 1 second. If you want to correct respiratory acidosis, then you have to increase the bicarbonate. Bicarbonate has to increase. Okay, bicarbonate increasing will correct the pH. pH is low. If bicarbonate increases, pH will eventually get high and pH will get normal. So bicarbonate has to increase by the renal system. How does the renal system increase bicarbonate?
Reabsorption.
Increased reabsorption.
Will it take more time or less time?
more
time.
Delayed compensation. So always remember, renal compensation is a delayed mechanism. Next one is if we have a patient with respiratory alkalosis, in a patient with respiratory alkalosis, what happens with the partial pressure of carbon dioxide?
Decrease.
Partial pressure of carbon dioxide is increased. pH is increased. So if pH is increased, do you want to increase more bicarbonate or less bicarbonate?
Less.
Decrease bicarbonate.
Yes. What you need is you need to have less bicarbonate. Very good. So bicarbonate has to decrease. How will the bicarbonate decrease? By decreasing the reabsorption.
Increase excretion.
Decrease the reabsorption as a result. Decreasing bicarbonate reabsorption from the renal system. This is also a delayed mechanism. Are we clear now?
Yes.
Okay. So what I will need you guys to do is I will need you guys to read this once while I make the table. And first of all, let me thank you for participating actively. Okay. First of all, let me thank you for. And what I will need you guys to do, I will need you guys to read this once. After you guys read this once, you guys will master it 100%. And then I will need the help of 4 students who can answer me the changes that are occurring in pH, carbon dioxide, and bicarbonate level. Okay, so please read the table while I make the table over here for your questions. The table once. Okay, is Dr. Hussam over here? Dr. Hussam, are you here? Dr. Hussam.
Yes, doctor.
Okay. Do you remember you asked me a question about why spironolactone is causing metabolic acidosis? Yes or no?
Yes.
Okay. So so this is for everyone who has the same confusion. The question is how and why does spironolactone causes metabolic acidosis? Okay. If we have spironolactone, what is spironolactone? It's a potassium sparing diuretic. If we spare the potassium, will there be increased potassium in the blood? Yes or no?
Yes.
Yes, obviously, if we spare the potassium, there will be increased amount of potassium in the blood. If there's increased amount of potassium in the blood, will this potassium try to enter the cell? Yes or no?
Yes.
How does potassium enter the cell? Via the hydrogen potassium channel? Yes.
Yes.
So if potassium gets inside the cell, will hydrogen get released from the cell?
Yes.
If hydrogen gets released from the cell, can this increase the pH of the, I mean, like, can this decrease the pH because there's increased amount of hydrogen? Yes or
Of
no?
course, yes, yes, yes.
Oh, so this is how metabolic acidosis is occurring in spironolactone. Okay.
Thanks,
Okay.
doctor.
So with that being said, can I get the names for 4 physicians who can help me out with base physiology? Dr. Adhanom, thank you. Dr. Imad, thank you. Dr. Sheikh Yusuf and Dr. Mohammed. Thank you so much. Okay. So, that's what we will do. Okay. Dr. Imad, it will be better if I ask Dr. Nawal because we have participated. Okay, so we will start with our Dr. Adhanom. Dr. Adhanom, would you be kind enough to tell us what are the changes that you will see in metabolic acidosis? Let's start with pH. What happens in pH? Dr.
Low,
Adhanom,
decreased.
very good. What happens to bicarbonate?
It is decreased.
Very good. As a result, will you try to hyperventilate or hyperventilate?
We have to hyperventilate.
Rest. Very good. If you hyperventilate, your partial pressure of carbon dioxide will also be
Will
decreased.
decrease. Yeah.
Thank you so much. Next one. Next question goes to Dr. Sheikh Yosef. Okay, Dr. Sheikh Yosef, would you be kind
Yes,
enough?
doctor.
Yes. Would you be kind enough to tell us what are the problems that you can see in a patient with metabolic alkalosis? What happens to pH?
Increased.
pH is increased. Very good. What happens to bicarbonate?
Increased.
Increased. As a result, will you try to hypoventilate or hyperventilate?
Hypoventilate.
Yes, because you want to increase the partial pressure of carbon dioxide. Am I correct? Yes or no?
Yes.
Okay, so you will try to increase the partial pressure of carbon dioxide. Very good. Okay, thank you so much, Dr. Sheikh Yosef. The next one goes to Dr. Mohammed. Dr. Mohammed, you didn't participate before, I guess so. I can't remember. Okay, so
I
Dr.
did participate. If
You did
anyone wants
participate
to,
before.
it's
Okay,
okay.
thank you for letting me know. In that case, I would like to ask someone else who did not participate as of yet. That is Dr. Lala. Okay, Dr. Lala, would you be kind enough to tell us what are the changes you would expect in a patient with respiratory acidosis? Let's start with the pH. What happens in the pH?
Decrease.
pH is decreased. As a result, pH is decreased because of changes in PCO2 or bicarbonate. Which one?
PCO2.
Very good. PCO2, is it increased or decreased?
Decrease.
Increased. Okay. As a result, if you try to compensate renally, will you try to increase bicarbonate or decrease bicarbonate?
Increase by renal reabsorption.
Very good. So you will try to increase your bicarbonate. Very, very good. This is very easy. Okay, thank you so much. And can we have another physician who has participated before? We have not heard much from Dr. Naud, who wants to participate. Dr. Naud, would you be kind enough to tell us what are the changes that you can expect to see in a patient with respiratory alkalosis? Okay.
Respiratory alkalosis, obviously the pH is going to be high.
pH is going to be high. Thank you. pH is high because of change in PCO2 or bicarbonate?
In terms of, because its name indicates respiratory in PCO2.
Very good. So what happens to PCO2? Is it increased or decreased?
It's going to be low.
Very good. So what will you do? Will you try to increase reabsorption or decrease reabsorption of bicarbonate?
Decrease reabsorption.
Decrease reabsorption of bicarbonate. Okay, thank you so much to all the physicians who participated, and to all the physicians who wanted to participate, and to all the physicians who did not participate. Okay, thank you so much for understanding this table. Before we move on to Henderson-Hasselbalch equation, which is another high yield thing that we have to understand, we also have to master the Winters formula. When both of them will do it right now. But before we do that, have we understood the pH, PCO2, and bicarbonate changes table? Dr. Nadine, is it clear to you now? Dr. Nadine, is it clear to you now? Hopefully it should be clear. Okay, if it's not clear, no problem, you can ask me again. and I will explain it again. No problem. Okay. Now I want to discuss something. What I want to discuss is um, first of all, I want to discuss about the Winters formula, and then I want to discuss about Henderson's Hasselbalch equation. Okay, Henderson-Hasselbalch equation, because the Winters formula is more tested in your USMLE step one than Henderson-Hasselbalch equation. Okay. Okay. So the thing is, can I will need you guys to unmute yourself and answer me question. Just say yes or no. That would be enough for me. Okay. If you have a patient scenario in your UWorld, do you remember that they gave out certain informations in the questions, such as they will tell you the pH, they will tell you the PCO2 level, yes or no?
Yeah.
Yes.
Yes.
Some random informations they will give out to you. Okay, they will give out to you some random informations. Okay, so the thing is, what they want you to see is they would want you to see if there is compensation or not. Okay, so the thing is, if a patient has metabolic acidosis, if a patient has a metabolic acidosis, do we want to compensate it respiratory wise or renal wise?
Respiratory.
Respiratory wise. Okay, so
Respiratory.
Winter's formula is basically a formula that is used to see if there has been proper respiratory compensation for metabolic disorders. Okay, so first and foremost, Winter's formula is to see that has there been a proper respiratory compensation. In order for proper respiratory compensation, what do we have to measure? We have to measure partial pressure of carbon dioxide. Okay, can I get 1 second, please? 1 second.
Okay.
Okay, so is everyone back from the break? Apologies for that small break. Okay, I guess everyone's back. I'm over here waiting, ready to start. Okay. Okay, perfect, perfect. Okay, let's see what's going on over here. Okay, so I guess we're all back from the break. Okay, let's go back to our discussion. Okay, so what we were doing was, once again, you have the liberty to unmute yourself and ask me questions because we want to get this fast. Okay, so basically, the thing is, we want to discuss metabolic acidosis and proper respiratory compensation to make sure if the patient's respiration is being is compensating the metabolic problem. Okay, so how do we do that? Basically, the way that we can do this is, first of all, in a patient scenario, you have a patient with a proper pH, PCO2, and all these other information that you will be given. And then you have to see whether you will say, let's say you will have a patient scenario where they will tell you blah, 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 this. And then you will have answer options like these four, where there will be metabolic acidosis with respiratory compensation, metabolic alkalosis with respiratory compensation, metabolic acidosis without respiratory compensation, and metabolic alkalosis without respiratory compensation. Now, how do you know the respiration is being compensated or not? Fortunately, there is a simple formula which we have to use in order to figure out that there has been proper respiratory compensation or not. And this respiratory compensating formula is known as Winter's formula. Winter's formula, this basically is the formula that is PCO2 is what is important for respiratory compensation. Yes or no? Yes or no? Is
Yes.
PCO2 the respiratory
Yes.
compensation
Yes. Yeah.
For respiratory.
component? Yes or no?
Yes,
Yes.
yes.
Okay, once again, you guys are at liberty to unmute yourself and answer my questions. I don't want to go back to the
Doctor, I
slide.
think you are muted.
So in order to see whether there has been proper respiratory compensation, you have to measure PCO2. Yes or no?
Yes.
Yes, yes. Doctor, you can hear us?
Guys, any feedbacks? Okay. I'm muted. Can you guys not hear my voice?
Yeah.
We can hear you.
Oh,
Hello.
okay. You can hear me, but I can't hear you guys. Okay.
Yes.
That is absolutely inconvenient for right now. Okay, whatever. But let's move forward. Okay, let's see. After that, I will refresh the meeting. No problem. Okay, let's finish this. So PCO2. So right now you have to see that the PCO2 has this been compensated or not. In order to see if the PCO2 is compensated, what we will do is we will see 1.5 into bicarbonate
Plus 8 plus or minus.
plus minus, sorry, it's not plus minus, it's plus 8 plus minus 2. Okay, plus 8 plus minus 2. So the thing is, next time you find a patient with a metabolic acidosis or metabolic alkalosis, and let's say they tell you that the bicarbonate level is, let's see, they tell you the bicarbonate level is 60, for example. They tell you the bicarbonate level is 60. And now if they ask you, if the bicarbonate level is 60 and they tell you the patient is having metabolic alkalosis and you want to find whether the patient has respiratory compensation or not, all you have to do is put this number over here, multiply it by 1.5. What is 60 into 1.5? That is close to around how much?
90.
90.
Right? Should be 90. 90 plus 8 plus minus 2. So your answer should be either 98 or 96.
100.
98 and 96. This should be the partial pressure of carbon dioxide.
And also 100.
If this partial pressure of carbon dioxide that you have just calculated, if this partial pressure of carbon dioxide matches the partial pressure of carbon dioxide value given in your question, if this and this is the same, then has there been proper respiratory compensation? Yes or no?
Yeah.
Yes.
Okay. Has there been proper respiratory compensation if this matches?
It 196, right?
If this predicted one versus the given one, if this is the same, has there respiratory compensation in the patient or in the for which the question has been made? Yes or no? Yes. Okay. So then you can say that the patient has had metabolic alkalosis with respiratory compensation. Are we clear? Are we clear? Okay. If it does not match, has there been respiratory compensation? Yes or no? No. Okay. Once again. Okay. Okay. Let's see this. Okay. I really need you guys. I really need to hear your voice. You need to hear the voice. Let's see. Okay. One second. Let me come back. Okay. Let me come back.
شنو يا عمو؟ أو قاعد يشرب صودا. أنا ما عايزة. ليه فتحت شنو؟ But you open.
Okay. Can you guys hear my voice now? I mean, can you guys talk now?
Yeah.
Can you hear us, doctor?
Hey, congratulations. Welcome. Thank you.
Finally.
Yeah.
Finally. Okay, perfect. Okay. Now we will discuss it once again. Thank you so much for having your patience. Okay, for Dr. Nadeem, who was confused, I will repeat it once again for you. Okay, so let's say you have a UWorld question where they have a patient scenario. They tell you a 35-year-old man comes to the emergency department with this symptom, blah, 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 right? Then they will have some lab values over here. They will tell you they will have a pH, right? They will give you the pH. They will give you the PCO2. They will give you bicarbonate, right? This is your question of UWorld.
Doctor, the screen, please, if you can share.
Oh, my bad. Okay, I'm sorry. Okay, so this is the question, and then you will have pH, PCO2, and bicarbonate. pH, PCO2, and bicarbonate. Okay. So in these type of questions, you will have answer options such as metabolic acidosis with respiratory compensation, metabolic alkalosis without respiratory compensation. Then you have metabolic acidosis with respiratory and metabolic alkalosis with respiratory compensation. So in order to answer the right one, first of all, you have to see whether if it's metabolic acidosis or metabolic alkalosis. If the pH is less than 7.35, metabolic acidosis. If it's more than 7.45, it's metabolic alkalosis. That's the first one. The next thing is you have to see whether there has been proper respiratory compensation or not. Okay. In order to see respiratory compensation, that is PCO2 level, you have to measure the Winter's formula. That is the bicarbonate value given over here. You have to put this bicarbonate value in this equation. That is 1.5 into bicarbonate plus 8 plus minus 2. Plus minus 2. Okay. So the thing is, I'm sorry, I think this should have been 100. 100 or 98. Okay. So the thing is, let's say that the bicarbonate value given over here was 60. So you put the 60 over here, and then you measure the PCO2. The PCO2 level came to around 100 to 98. Okay. So 90 plus 8. 1.5 into 60, that is 90. 90 plus 8 is 98. 98 plus minus 2. So 98 plus 2 is 100, and 98 minus 2 is 96. So 100 to 96. So if the PCO2 level is between 100 to 96, this level over here and this one, if it's the same, then there has been respiratory compensation. If it's not the same, then there is no respiratory compensation. So if the pH is more than 7.45, your answer should be metabolic alkalosis without respiratory compensation. If it does not match, if it does match, then it's metabolic alkalosis with respiratory compensation. Is it clear now? Is it clear now? Everyone?
Yeah.
Okay, congratulations. Perfect.
Yes, yes.
Okay, perfect. Another thing, okay, it's not that simple. There is another complication over here. There's another thing. There's another way you guys will get these questions. That is, they will give you these type of patient scenarios, and after that, they will ask you questions to see whether there has been mixed acid-base disorder. Mixed. What is a mixed acid-base disorder? Mixed acid-base disorder is to see that there has been, or is there any other respiratory, is there any other acid-base problem with the primary problem? So once again, if you measure the Winter's formula, that is if you have PCO2, that is 1.5 into bicarbonate, right? And then that's plus 8, then plus minus 2. This is your Winter's formula. If you see that your value, okay, is less, let's say that your value came to, let's say, 20. The value of PCO2 in your question is 30. Okay, the PCO2 value given in your question is 30, but your value came to 20. If the measured, that is the PCO2 value, if it's given 30 in your question and your one is 20, okay, then this patient has mixed acid-base disorder, that is respiratory acidosis. Respiratory acidosis. Okay, what's going on over here? What's going on over here is that what is a mixed acid-base disorder? That is, in a patient with metabolic acidosis or alkalosis, the patients can have metabolic acidosis with respiratory acidosis or metabolic alkalosis with respiratory acidosis. In order for us to realize if this patient is having a mixed acid-base disorder or not, we have to measure the Winter's formula to see that, for example, if this patient has metabolic alkalosis, and if you see in your question stem, you don't have to do this equation all the time. If you do not see the options for mixed or compensatory answer options in your answer stem, if you see that in your answer stem, they have mentioned mixed, let's say you have A, B, C, D, and they say mixed, okay? In order for you to cancel out mixed, or in order for you to see if the mixed is the right answer, then you have to do the Winter's formula to see if this values matches. If it's not mixed, then the values will be the same. That is your PCO2 level, and the question's PCO2 level will be the same. Let's say your comes to 20, and the question also contains PCO2 level, that is 20. So the patient does not have a mixed acid-base disorder. The patient only has the normal one acid-base disorder. Another one is if your value is more than the one, let's say the measured one is 15. Let's say the measured value in the question is 15 and yours is 1. So this patient now has respiratory alkalosis. Okay, this patient has respiratory alkalosis. That is the mixed acid-base disorder, the one with the primary acid-base disorder in concern. And remember, you have to do this only when you get this mixed option in your question. If you see the mixed option, first and foremost, do the Winter's formula to come up with a value, then measure the value with the one given in your question. If it's more, then it's respiratory alkalosis. If it's less, then it's respiratory acidosis. This is for mixed. Another one is you can also do the Winter's formula to see if there has been proper compensation or not. Are we clear on this? Yes or no? Yes or no?
Yes.
In order for you to completely understand this, In order for you to completely understand this, you have to come across a question. You have to come across a question, okay? How can we check for compensation in respiratory acidosis and alkalosis? In compensation, the values have to match. There should be matching. Let's say your value comes to 20. The question also has 20, so your values are the same. So there has been compensation. Okay. Dr. Abed, what is your question, please? Dr. Abed, what is your question? No, it depends on the pH. If the pH is, it all depends on the, it all depends on the pH of the patient in your question. If the pH is more, it's alkalosis. If the pH is less, it's acidosis. Okay, are we clear? Are we clear?
Yes.
Okay. But a metabolic one, even in metabolic acidosis or alkalosis, you have to consider the pH. If the pH is less, it's alkalosis. pH is more, if the pH is less, it's acidosis. If the pH is more, it's alkalosis. Okay, Dr. Hussein, you said no. What is your question, please?
Please repeat the mix. I'm confused here.
Okay, good. So mixed. I will repeat the mixed one again. Okay. Okay. So Dr. Hussein and who else has the confusion? Let's see. Okay, Dr. Hussam. Dr. Hussam also has the confusion, and Dr. Hussein, you guys have the confusion. So please unmute yourself and answer me questions. Can you guys hear my voice?
Yeah.
Yes, yes.
Okay. So first of all, Dr. Hussam and Dr. Hussein, you guys come across a UWorld question, okay, where you have all this information over here. Keep in mind, I'm discussing the mixed problems. Then you have a value for pH. Then you have a value for PCO2. Then you have a value for bicarbonate. Let's say pH is 7.8. PCO2 is 15. Bicarbonate 60. Okay. Now, this is your question. In your answer, you have metabolic acidosis, metabolic, okay, A, B, metabolic alkalosis. And then you have mixed acid-base disorder, or you have some kind of other information. Let's say you have metabolic alkalosis with respiratory acidosis. Let's say you have these kind of answer options, and this is a possibility this could happen. Dr. Hussam, can you hear my voice? Dr. Hussam?
Yes, yes, I can hear.
Okay.
Mm-hmm. Mm-hmm.
So, Dr. Hussam and Dr. Hussein, first of all, what will you do? What will you do? What is the first step you will do? Measure the pH, right? pH is, does the patient have metabolic acidosis or alkalosis?
Alkalosis.
Alkalosis.
It's alkalosis, okay? And depending from what we can see, that the bicarbonate is very high, so it should be alkalosis. Let's make the bicarbonate 80. Let's make it 80. Bicarbonate is very high, pH is very high. The patient has metabolic alkalosis, okay? So now do you also have to make sure that it's not a mixed acid-base disorder, right? Because they have answer options over here. Am I correct? Yes or no? Do you also have to make sure that that these are crossed out?
Yes.
Okay.
Yeah.
In order for do that, what do you do?
Winter's formula.
Winter's formula, okay? Winter's formula. So you do the winter. That is PCO2 that into 1.5 into bicarbonate, and then plus 8 plus minus 2. That's the Winter's formula.
Okay.
In the PCO2, you find that your value is less than this value. Then the patient has mixed acid-base disorder. respiratory
Oh.
acidosis. If it's more, then if your value is more than this value, then the patient has mixed acid-base disorder with respiratory alkalosis. Am I clear now?
What do you mean this value, doctor?
Yes.
Clear? Okay.
Mm.
Okay. All right.
Okay.
Perfect. Thank you so much for keeping your patience. Okay. Is everyone clear after this breakdown, another breakdown?
Doctor, you said if your value is more than this value, what do you mean by this value?
This value, meaning the value provided in the question versus the value which you come up with the Winter's formula. Okay. This is the measured. This is the predicted. Are we clear?
Yeah, doctor, I have a
Yes.
question.
Well, what is your question?
Yeah, there is, I guess, in your question, there is how to measure compensation for respiratory alkalosis and respiratory acidosis.
Or
There
how?
is any formula for
No,
to
no,
know
no.
this respiratory acidosis or
No formula. Who do I have the pleasure of speaking with?
Sarah Hussein?
Okay, Dr. Hussein, for Winter's formula, you only have to see if there has been respiratory compensation or not for metabolic, not any compensation for renal compensation. Okay, no equation for renal compensation. Are we clear?
Okay.
Okay, perfect. Next question. But if from Dr. Abid, but if the question about respiratory ones, not metabolic ones, we don't use the formula. Yes, we don't use the formula. You will not get 100%. You will not get questions regarding respiratory acidosis or alkalosis, and they will never ask you if the patient is being compensated. Do you know why? Because the compensation is very delayed. The compensation is very delayed, and this delayed compensation is not properly calculated. So that's that. Okay. Okay. Are we devoid of all questions and confusions? Have we understood Winter's formula? Doctor, my question, please. Yes, Dr. Nadine, what is your question? Doctor, if same exclude, doctor, if same exclude mixed. If same, I apologize, I cannot break down your question. Could you please rephrase your question? Could you please rephrase your question? We don't have a lot of time today. We have to finish this. Anyone else? Dr. Nadine, would you mind rephrasing your question? If PCO same as question, we exclude mixed. PCO, if PCO is same, we exclude, okay. If PCO is same, we exclude mixed, yes. I apologize, I'm sorry it took me so long to understand your question. If PCO is the same, then we can exclude mixed, okay? Are we clear now? Okay, perfect. Okay, good. So everyone, hopefully you guys have all understood this whole breakdown. Okay, if you guys have any further questions, please don't hesitate to ask me at the end of the lecture. Okay. Next one I want to talk about really quick is Henderson-Hasselbalch equation. Henderson-Hasselbalch equation is basically your equation to figure out the pH. Okay, so let's say if you ever get a question, which I doubt you will ever get in your USMLE, because the reason is Henderson-Hasselbalch equation has a problem. That is, Henderson-Hasselbalch equation has to be solved by log. Okay, so the only reason you would need Henderson-Hasselbalch is to measure the pH. That is pH equals 6.1 plus log bicarbonate divided by 0.03 into PCO2. Okay, extremely unimportant equation. The reason being is you will not get a lot of questions. The reason is because you have to put the values over here, then you have to do a log. The calculator in your USMLE does not have that kind of mechanism. Highly doubt you will ever come across a question with this Henderson-Hasselbalch equation. I personally have not seen any question in your UWorld. If you do come across a question about Henderson-Hasselbalch equation in UWorld, please don't hesitate to share it with us, because we would also like to know how they would ask questions from the Henderson-Hasselbalch. But it's very highly unlikely you will receive any question from Henderson-Hasselbalch equation. Okay. With that being said, can we move on to the next page? This page has been very difficult to master, but Have we completely mastered and understood the last page? Acid-base disorder is very important. You will receive a lot of questions from acid-base disorder. It's a very important topic. That's why we took some time. Yes, you are provided calculator. You have the calculator in the simulator. You will have the calculators in the simulators. Okay. Great. Let's move on to the next problem. Okay, let's move on to the next page. The next page is the next page that we want to discuss is renal tubular acidosis. Renal tubular acidosis. This is the disorder of the renal tubules that causes a normal anion gap metabolic acidosis. Okay, normal anion gap metabolic acidosis. Before we move on and jump to this last page of the physiology, do you guys want to take another 5-minute break? Yes, because there has to be some memorizing that has to be done.
Yes, please.
Okay, yes, please. Okay, so let's take another 5-minute break so that we can reorganize ourselves and come back, because this is the last page of first aid that we might be reading today. Or we might start a little bit of pathology. I'm still not sure, but there has to be a lot of understanding, reviewing, and memorizing that needs to be done for this page. So 5-minute break should do everyone good. Okay. Okay, is everyone back from their break for 5 minutes? Is everyone back from their break for 5 minutes? Okay, perfect. Okay, perfect. So what we are going to do is we're going to begin. Okay, we are going to begin. And once again, you guys have the liberty to unmute yourselves and ask me questions. If you guys have any question, can I hear yes or no to understand it? Yeah, I can hear voices. Yes,
Yes.
or no? Okay, perfect.
Yes.
Okay, so what we're going to do is we're going to begin with renal tubular acidosis. Are you guys tired? Yes or no? I apologize for taking such a long lecture for today, but have you guys understood renal physiology? We are very close to finishing it. This is the last topic. Are you guys tired? Can we do one more? Yes or no?
Okay, we can do one more.
Yeah.
Okay.
Okay, perfect. Thank you so much. Okay, RTDs. How important is RTD?
Very important.
Very good. RTDs are very important, 3 stars. We will learn about RTDs. If we can learn this, this is the difference between your score of
Can you eat breakfast?
217. Did we just hear a baby asking if they can eat breakfast? Yes or no? Okay, so this is the difference between your score of 217 to 230. Not a lot of students can answer renal tubular defects properly. If you can answer renal tubular defects in your actual exam, because the high stress of the exam will prevent you from making the correct choices with renal tubular defects, because it's a bit difficult. But knowing our lectures, we will try our best to break it down. Okay, having said that, how many types of renal tubular defects do we have? My first question, how many types of renal defects do we have? We actually have, for the purpose of your step 1, renal tubular defects, we have 3 defects. 3 defects, but the problem is the names are type 1, type 2, type 4. Where is type 3? There is a type 3, but this is beyond the scope of step 1.
Yes.
There is type 3, but that is beyond the scope of step 1. We don't have to understand or associate type 3. First one that we want to talk about is type 1. So what we are going to do is we're going to explain type 1. What happens in type 1? Type 1 is also known as distal renal tubular defect. Distal renal tubular defect. This is type 1. What is the defect? Of course, renal tubular defect. The word says it itself that there is a problem with one of the portions of the renal tubule. We have this whole tubule over here. Something is wrong at some portion. Okay, that is the problem. For type 1, the problem is over here. The problem is over here. What is the problem? The cell that is over here is alpha intercalated cells. Okay. Do you guys know what alphas are? Alpha. Alpha means the best, number 1. Alpha is number 1. Okay. Who are the alphas? Alphas are the number 1s. Okay. Then we have betas. The betas are beyond the alpha. Okay. So there are phrases like he's the alpha or she's the alpha of the group, or if there's a gang of wolf, the alpha of the gang will guide the wolf. And like in a pack of animals, alpha is always the number 1. So alpha for type 1, alpha intercalated cell defect. What is the problem? The problem is in alpha intercalated cells, do you remember how we said that there are hydrogen pumps?
Yes.
There are hydrogen pumps. Okay. The hydrogen pumps, what do? They release hydrogen, right? They release hydrogen, and the problem in alpha intercalated cells is these pumps are not working. If these pumps do not work properly, can hydrogen leave the tubules into the urine? Yes or no?
No.
No. So
No.
will this hydrogen be absorbed in the blood or remain in the blood? Yes or no? Yes or no?
This hydrogen remain in blood. Yes.
hydrogen will stay in the blood because this pump over here is not working, the pump in alpha intercalated cells. This hydrogen will remain, if this remains in the blood, will there be metabolic acidosis or will there be metabolic alkalosis?
Acidosis.
Acidosis. As a result, patients will have metabolic acidosis. So renal tubular acidosis or renal tubular defects or renal tubular acidosis are basically metabolic acidosis, more or less. These are more or less metabolic acidosis because of problems of the renal tubule. Are we clear? So acidosis due to renal tubular problems is renal tubular acidosis. Out of them, type 1 is the problem of alpha intercalated cell. In alpha intercalated cell, the hydrogen pump is not working. If the hydrogen pump does not work, hydrogen cannot leave. Excess amount of hydrogen in the blood can cause metabolic acidosis. Are we clear? Yes or no?
Yes.
Okay.
Yes.
Okay. Now the thing is, if the hydrogen cannot enter into the urine, what will happen to the urine pH? Will it be high or low?
High.
Alkali.
There you go. Urine pH will be high and serum pH will be low, right? The pH of the blood will be low. What are the causes of type 1 acidosis? What are the causes of type 1 acidosis? Okay. Okay, the causes of type 1 acidosis, we can remember the causes of type 1 acidosis by this friend of ours. Okay, do you guys know the name of this friend? This friend of ours, her name is Jane. Have you guys heard of Jane before?
Yes, many times.
Very good. Jane is our friend. Jane helps us understand first aid. Okay, what is the problem with Jane? Okay, Jane has a problem, that is, Jane has these types of rash, like a butterfly. Well, what does Jane have?
SLE.
SLE.
Jane has SLE. In SLE patient, can we have problems of the kidney? Yes or no?
Yes.
Yes.
Okay. So so Jane, along with SLE, Jane has pain in the kidneys, painful kidneys. Okay, painful kidneys. For this pain in the kidney, Jane has a lot of NSAID. Okay, Jane has a pain in the kidney, so for that, Jane has a lot of NSAID. Okay, and in a patient with SLE, can there be immunocompromisation? Yes or no?
Yes.
Okay, good. So for the immunocompromisation, Jane also has a urinary tract infection, for which Jane takes a lot of, for which Jane takes a lot of amphotericin. For some reason, Jane thinks that having amphotericin will help her.
Yeah, fungal infection.
Help her with her UTI, but she does not have the proper knowledge of physicians. So she has a lot of amphotericin. So she has now, what she has is she has amphotericin toxicity. Okay, so Jane with SLE, pain in the kidney, she had a lot of NSAID, amphotericin toxicity. Okay, another thing which Jane had was, since her birth, Jane had an anomaly or a problem of the urinary tract. That is, Jane had congenital anomaly of urinary tract. So this is Jane. Who is Jane? Jane is our friend who has SLE. Jane has a lot of NSAID. Jane abuses amphotericin for her UTI, and Jane has a congenital anomaly of the urinary tract. These are the 1, 2, 3, 4 causes of renal tubular acidosis type 1. Are we clear? Yes or no?
Yes.
Okay, are we clear?
Yeah.
Doctor, what is co-AVT?
Congenital anomaly of urinary tract. Congenital anomaly of urinary tract. Are we clear? Guys?
Yes.
Okay, can
Yes,
can you please use this mnemonic to memorize the causes of distal renal tubular acidosis?
Yeah.
Okay.
Of course.
Okay. Now the thing is, if we have urine that is high in pH, can this be a cause for increased renal stones? Because
Yes.
for renal stones to occur, do you guys remember how I told you that calcium deposits in alkaline condition. Do you guys remember that?
Yes, yes.
Yeah.
So if the pH is increased, can there be increased amount of calcium in the urine?
Yes.
Yes.
This can
Yeah.
cause calcium phosphate kidney stones. Okay, if you can remember this page, then you have understood everything about renal tubular acidosis type 1. Are we clear? Are we clear on this?
Yes.
Yes.
Okay. Can we ask if I was not wrong? I think I heard Dr. Adenom. Dr. Adenom at random, would you be able to tell me the 4 causes of renal tubular acidosis type 1, please?
Yeah. It
First
is
of
the
all, let's
story
take off
about Jane.
Jane. What does Jane have?
She has SLE.
Number 1. Number 2.
She has also kidney pain. Therefore, she takes non-steroidal anti-inflammatory drugs for it.
Number 2 is NSAID or analgesic nephropathy. Number 3.
Number 3 is she also takes amphotericin B.
Amphotericin toxicity. That's number 3. Number 4, she had a congenital problem. What was the problem?
Yeah, congenital anomaly of the urinary tract.
Okay. Now, since Jane has increased urinary pH, can Jane also have calcium phosphate kidney stones?
Yes, calcium
phosphate.
phosphate.
So that is all the information. And if I have to ask you, type 1, are type 1 number 1, are alphas number 1?
Yes.
Okay.
Yeah.
If alpha is number 1, then where is the problem with type 1 acidosis?
It is in the alpha intercalated cells.
What is the problem in alpha intercalated cells?
There will be no secretion of hydrogen ion.
As a result?
Therefore, as a result, it will increase in the blood.
Right. And the patients will
cause
have
metabolic acidosis.
Perfect. That is absolutely wonderful. Okay. And now what we will do is we will move on to number 2. Okay. Number two is known as proximal renal tubular acidosis. Okay. Number 2 is known as proximal renal tubular acidosis. This is type 2 that we want to talk about. Type 2 is known as proximal. That one was known as distal. This is known as proximal renal tubular acidosis. Proximal renal tubular acidosis. P for proximal, P for PCT. PCT stands for proximal convoluted tubule. Where is the defect of type 2? Fast answers, please. Guys, where is the defect of type 2?
Proximal convoluted.
Very good. So P for proximal renal tubular acidosis and P for proximal convoluted tubule. What is the defect? The defect is in proximal convoluted tubule, the main defect is in proximal convoluted tubule, you have, do you guys remember I talked about the fact that you have sodium bicarbonate co-transporters, right? In this defect, the bicarbonate transporters, they fail. They are not working. As a result, will you have more bicarbonate in the urine or less bicarbonate in the urine? Last answers, please.
More bicarbonate.
More bicarbonate in the urine. If there's more bicarbonate in the urine, then will there be more bicarbonate in the blood or less bicarbonate in the blood?
Less.
If there's less bicarbonate in the blood, less bicarbonate, this is more in urine. If there's less bicarbonate in blood, will the pH be high or low?
Low.
Low pH. So will the patients have metabolic acidosis or metabolic alkalosis?
Metabolic acidosis.
Once again, this is metabolic acidosis due to a renal tubular problem. Renal tubular problem. Okay. Now the thing is, the difference between this and this is okay. So before we do that, do you guys remember that in alpha intercalated cells, we have hydrogen being secreted in the urine? Yes or no?
Yes.
Okay. So in alpha intercalated cell, what they will do is they will detect that the urine has a high pH. So they will try to increase the hydrogen ion secretion into the urine. But this hydrogen ion secretion will not be enough to overcome the alkaline condition of the urine. So overall, the bicarbonate will decrease. So the alpha intercalated cell will try to compensate, but will fail because there is high amount of bicarbonate which is leaving the urine. So but alpha intercalated cell will fail to compensate the alkaline condition of the urine. Okay.
Type 2, yes?
Yes, right. Now the thing is, okay, now the thing is, what are the causes of proximal renal tubular defect? Proximal renal tubular defect. The causes. What are the causes of proximal renal tubular defect? Okay. You know, our friend Jane, Jane has, Jane is actually very rich. Jane is actually very rich. And the thing is, Jane has a lot of cars. Okay. Jane likes to collect a lot of cars. That's her hobby. She likes to collect a lot of cars. But the thing is, she likes collecting old cars, not the new cars with AC. Okay, so she likes collecting old cars with fans, like cars in the 1920s or 30s, which did not have ACs, but she installed fans. Okay, she installed a lot of fans inside the car. She installed a lot of fans inside the car. Okay, so this Jane for a lot of cars. Okay, how many cars does she have? She has multiple cars. How many cars does she have? She has multiple cars. Multiple for multiple myeloma, cars for carbonic anhydrase inhibitor, and old cars with fan instead of AC for Fanconi syndrome. Are we clear on this?
Yes.
Can you repeat the mnemonic?
Yeah, so the mnemonic, once again, multiple cars for multiple myeloma, cars for carbonic anhydrase inhibitors, and cars with fans instead of ACs for Fanconi syndrome.
Okay.
Okay. Okay. Next one. So we're done with type 2. Okay. We will go back to first aid and see if we have missed out on anything, but these are the important things that we have to realize. Okay. Next one. If we have to ask this question, okay, can we ask this question to see who is confident to answer questions about renal tubular acidosis type 2?
Me.
Dr. Jordan. Okay. Dr. Jordan, Dr. Naud, Dr. Mohammed, everyone's confident. Thank you so much. Everyone is confident, but since Dr. Jordan, we have not heard much from her. Let's give her a chance to participate. Dr. Jordan, would you be kind enough to tell us where is the main problem with renal tubular acidosis type 2?
In type 2, we have a defect in proximal convoluted tubules and the sodium bicarbonate.
Okay, good. So, but the next question is, in proximal convoluted tubule, if there is a defect, do we have increased loss of bicarbonate or increased gain of bicarbonate?
So we will have more bicarb in urine and less in blood.
Okay, right. As a result, will the patients have metabolic alkalosis or metabolic acidosis?
They will have metabolic acidosis.
Okay. What will happen to the, can you just give me 1 second? What will happen to the urinary pH?
Urinary pH will be high.
Okay, urinary pH will be high. Okay, next one is, what are the causes of type 2 acidosis?
The causes are Jane had many cars, so multiple myeloma, and Fanconi syndrome,
okay,
and the cars carbonic anhydrase inhibitors.
Carbonic anhydrase inhibitors. Thank you so much for participating, Dr. Jordan. Okay, so that's what it is, and we're done with type 2. Do not worry if we have missed out on any high yield information. We will go back to first aid and we will see if we have missed out on anything, but we are sure to have mentioned all the high yields and how to remember them. The last one that we want to discuss is type 4. Type 4 is a bit difficult, but at the same time, it's easy to understand because the number one cause of type 4 is hypoaldosterone. For some reason, if the patient, can you guys tell me one cause of hypoaldosteronism? Anyone? Very, very good. Addison's disease or primary adrenal insufficiency. If we have any patient with Addison's disease or there's decreased amount of aldosterone, or for some reason the aldosterone cannot go and the aldosterone cannot work, okay, if the aldosterone cannot work, for example, aldosterone resistance, will the patients have hypokalemia or hyperkalemia? Will the patients have
Hyperkalemia.
Hyper.
Hypo.
hyperkalemia? If the patients have hyperkalemia, will there be more hydrogen secretion or less hydrogen? Okay, if the patients have hyperkalemia, will the cell try to increase the shift of potassium inside the cell or outside the cell?
Inside the cell.
If the potassium gets inside the cell, will hydrogen try to escape? Yes or no?
Yeah.
Yes.
Yes.
If
Yeah.
hydrogen
Exchange.
escapes, if the
Acidosis.
hydrogen, right, if the hydrogen escapes. Now, do you guys know the mechanism by which hydrogen is released from the body via the urine? Is hydrogen released as hydrogen, or is hydrogen combined with ammonia to form
Ammonium. Yeah.
ammonium? Which one? Hydrogen or
As
ammonium?
ammonium.
Ammonium.
So in hypoaldosteronism, can we say that the ammonium secretion is increased?
Yes.
Can we say that the ammonium secretion is increased in hypoaldosteronism?
Yes. Yes.
Okay, but as a matter of fact, the amount of ammonium that is formed over here, this ammonium, okay, this high amount of ammonium that is formed, this is not secreted completely. As a matter of fact, what happens is this high amount of ammonium that is formed in the proximal convoluted tubule, I mean in the blood, what happens is when there is high amount of ammonium in the blood, okay, now there is high amount of ammonium in the blood, okay, if there is ammonium in the blood because it has combined with the ammonia, will the proximal convoluted tubule now try to make more ammonium or less ammonium? If you think about homeostasis,
More.
Less
no,
ammonia.
less ammonium.
Right,
The
excrete.
convoluted tubule will try to make less ammonium because there's already so much ammonium in the blood. And now all this ammonium in the blood, this can be released via the gut through stool or feces. So what happens is the proximal convoluted tubule, what they do is, the proximal convoluted tubule, they decrease the production of ammonia. And as a result, when they decrease the production of ammonia, overall, there is a decreased amount of ammonium excretion. Decreased ammonium excretion. All this extra ammonium that is present in the blood will go out through the gut via the feces, not via the urine. Are we clear on this?
Yes, but doctor, I know that ammonium excreted with urine. Yes.
Ammonium is excreted with urine if there's excess formation by the PCT. If proximal convoluted tubule increases the ammonia synthesis in the proximal convoluted tubule, if the ammonia concentration is increased, then that excess ammonia is converted to ammonium, and then there is increased amount of ammonium secretion in the urine. But for some reason, if there is intraserum increase of ammonia, that ammonia does not go through the urine, that ammonia leaves the body through the feces. Are we clear?
Okay.
So as a result, in a patient with hypoaldosteronism, with hyperkalemia, this is the main confusion that happens in type 4 acidosis, is this mechanism of ammonium excretion understanding, that in hypoaldosteronism, there is decreased amount of ammonium excretion in the urine. Are we clear on this whole breakdown?
Doctor, can you repeat?
Of course. So what happens once again in hypoaldosteronism, if a patient has hypoaldosteronism or aldosterone resistant, patients have hyperkalemia. If the patients have hyperkalemia, then what happens to the hydrogen ion? That's all I wanted to know. If there is increased amount of potassium in the blood, will the potassium try to enter the cell or try to exit the cell?
Enter the cell.
Enter the cell.
Potassium, if it tries to enter the cell, then hydrogen has to leave the cell, right?
Yeah. Yes.
Okay. So first of all, if hydrogen leaves the cell, will the patient be in a state of metabolic acidosis or alkalosis?
Acidosis.
The patient will be in a state of metabolic acidosis. This excess amount of hydrogen combines with the ammonia in the gut to form ammonium, and this excess ammonium is released via the feces. But the proximal convoluted tubule detects this excess amount of ammonium in the blood, and then they decrease the secretion. I mean, they decrease the synthesis of ammonia by themselves, and they have decreased excretion of ammonium in the urine. This is known as the type 4 renal tubular acidosis. Are we clear now?
Yes.
Okay. Do we have any more question before we move forward? Do we have any more questions before we move forward? Okay, hopefully not. If you have any question, please don't hesitate to ask. Okay, next one. Next one is, what are the causes of hypoaldosteronism? Okay, that's what we want to know. First of all, there could be adrenal insufficiency, so decreased aldosterone production, decrease aldosterone. Okay, next one. Next one is, if you have a patient with hyporenin. If we have a patient with hyporenin, will there be more aldosterone or less aldosterone?
Less.
Less aldosterone. If we use ACE inhibitors, will there be more aldosterone or less aldosterone?
Less.
Less aldosterone. Very good. If we use angiotensin receptor blocker, will there be more aldosterone or less aldosterone?
Less.
Less.
Less aldosterone. Very good. If we have a patient with who is having spironolactone. Spironolactone, that's not the one. I apologize. If we have another one, for example, if we have another condition, I forgot the condition. 1 second. Let me go back. Go back to the text. Even I get a bit confused. So decreased aldosterone. ARB, NSAID. Okay, heparin and
Boy has so much in common. Young Don. How do you spell Young Don?
Okay. Okay. If the patient has been taking heparin, or if the patient has been taking cyclosporin, okay, these are also the causes of type 4 renal tubular acidosis. How does heparin and cyclosporin cause renal tubular acidosis? Heparin and cyclosporin, what they do is they cause aldosterone resistance. That is, they prevent the proper functioning of aldosterone, so aldosterone cannot work up to its maximum capacity. As a result, patients can get type 4 renal tubular acidosis, and type 4 renal tubular acidosis is very difficult because the questions come in various ways, okay? The question comes basically in type 4 renal tubular acidosis is that you have to understand the patient has type 4 renal tubular acidosis by looking at the ammonium level. If you have a question where they talk about aldosteronism and ammonia together, this is a very important pointer. This is how you can detect an acidosis, renal tubular acidosis question. If they mention ammonia and, for example, potassium together in a question, please think about renal tubular acidosis type 4. This is how you can detect a renal tubular acidosis question. And once you can detect the question, you can answer the question. Okay. Having said that, are we all clear? Are we all clear? Okay.
Yes,
the mechanism. Okay, so we have a question from Dr. Nadine. You don't understand the relationship of escaping the cell and ammonia. Okay, you don't have to understand this. Or just keep in mind that when you have decreased aldosterone, potassium ion increases. When potassium ion increases, hydrogen leaves the cell to maintain the level. When hydrogen leaves the cell, hydrogen may bind with the excessive gut ammonia to form ammonium and then escape as feces. And if that does not happen, if that does happen, this is detected by the PCT, and PCT, that is a proximal convoluted tubule, detects this, and they cause a decreased ammonium synthesis.
Do you have a cut?
As a result, they have decreased ammonium excretion.
Do you have a cut?
Okay, so that's that. Okay, love and prayers to the little baby. Okay, that is what it is. Okay, have we all understood? Yes, what is your question, Dr. MS?
Like you say, like when the hydrogen it escapes, you're saying like it causes metabolic acidosis.
Right, that's correct.
But how does it cause metabolic acidosis if the hydrogen will be going into the tubules?
Because not all the hydrogen is used up to cause ammonium ion. primarily due to hyperkalemia. This causes release of the hydrogen ion into the serum, and in initial levels, it causes metabolic acidosis. And not all the hydrogen ion leaves the body by combining with ammonium. Are we clear?
Okay, so I guess.
Okay. Do we have any more questions or confusions? First and foremost, all you have to understand is renal tubular acidosis is basically metabolic acidosis due to renal tubular defects. Number one is defect of the alpha intercalated cell. Number two is due to the defect of proximal convoluted tubule. Number three is the defect of hypoaldosteronism. These are the three causes. Okay, are we clear? Yes, well, what is your question, Dr. Hassam? Yes, the serum potassium is important in the serum. We are going to go to the serum potassium, but have you guys understood the breakdown of the disease? Yes or no? Okay, is anyone confident to tell me the causes of the type 4 acidosis from the mnemonic that we used? Is anyone confident to tell me the causes of renal tubular acidosis? Anyone? Okay, we have one physician, Dr. Hussam. Do we have anyone else who is confident to answer the questions regarding renal tubular acidosis? Okay, no one else. So let's start with Dr. Hussam. Dr. Hussam, would you be kind enough to tell us what are the causes of type 1 renal tubular acidosis?
Okay, so hyporenism and ACE inhibitors.
No, type 1.
Type 1, okay. Type 1, what? Just let me just remember the pneumonia.
Remember Jane?
Yes, Jane with SLE. So SLE disease. She has kidney pain. She takes NSAID, yes, and she takes amphotericin for UTI. And last, what also?
Amphotericin, congenital anomaly of UTI. There's only 4 causes, so very good.
Yeah, congenital anomalies, yeah.
Can we talk about the causes of type 2, please?
Yes, Jane also has multiple cars with fans. Yes, so multiple myeloma, cars for
carbonic anhydrase.
Yeah, for carbonic anhydrase.
And
fans for Fanconi's anemia.
Very good. For Fanconi's anemia.
Fanconi's
Okay, very well. Very good. And what are the causes of type 4, please?
Yes, so hyporenism, ARBs, ACE inhibitors, heparin and cyclophosphamide.
Okay, then?
Potassium sparing drugs.
Not potassium sparing drugs. Potassium sparing drugs are not the one, but hyporenism, ACE inhibitors, ARB, heparin, and cyclosporin, right?
Yes, and renal insufficiency.
And adrenal insufficiency. Perfect. Okay, that is perfect. So thank you so much. Have you guys all understood?
You're welcome.
Okay. Can you guys remember the causes of renal tubular acidosis after our lecture? Everyone? Can you guys remember the causes of renal tubular acidosis after our lecture? Do not worry, I will not ask you questions. You can answer me. Yes or no? Okay, I have students over here who are very afraid to say, okay, yes or no, because they think I'm going to ask them questions. Do not worry, I won't ask you questions. Okay. Except for, okay, so the easiest way you can understand for 4 is when you think about the type 4 renal tubular acidosis, think about hypoaldosteronism. That is all you have to know. Hypoaldosteronism. Hypoaldosteronism can cause type 4 renal tubular acidosis, and try to think about all the causes of hypoaldosteronism and you can easily answer renal tubular acidosis type 4. Okay, perfect. Let's finish the lecture today by discussing the last topic, that is what happens to the serum potassium levels. Very easy to understand. Okay, what happens to the serum potassium level if hydrogen ion is increased in the blood, if hydrogen ion is increased in the blood, the hydrogen ion, what they will do is, if there is metabolic acidosis, does it cause shifting of potassium inside the cell or outside the cell? Fast answers.
Must be outside the cell.
What was the mnemonic for shifting of potassium inside the cell? Shifting of potassium inside the cell. Is it a bad habit to push someone inside the house? Yes or no?
Yes, bad habit.
Okay, so did we have acidosis for outside of the cell?
Yes.
Okay, so if it shifts the potassium outside of the cell, these patients should have hyperkalemia. Okay, so this is the problem. So if there is shifting of the hydrogen ions, what this will do is this will shift the potassium outside of the cell, but this excess amount of potassium is lost in the urine. Okay, excess amount of potassium is lost in the urine. As a result, the patients have decreased serum potassium ions. So the exact opposite thing happens over here. Are we clear? The same thing happens in type 1, the same thing happens in type 2, but in type 4, what happens is if you have hypoaldosteronism, if hypoaldosteronism, then the patients have hyperkalemia. Are we clear on this?
Yes.
Yeah.
Everyone.
So potassium initially increases.
Understood, but type 2, please.
Okay,
Type
one by
1,
one.
sorry.
Who has the first question?
So, Doctor, potassium initially increases, but it got lost or trashed in urine.
Right.
Yeah?
Right. That is correct.
Doctor, in the distal renal tubular acidosis, why potassium is decreased? Repeat, please.
Okay.
Because there is inability of alpha intercalated
Okay.
cells.
Right. So first and foremost, potassium should have increased in metabolic acidosis due to the patient has metabolic acidosis, and in metabolic acidosis, what happens is the potassium shifts outside of the cell. But over here, what happens is this amount of potassium is lost to the urine because the renal tubules, they do not have the capacity to retain the potassium say anymore. This is what happens in type 1 and type 2 because there is a defect. If there is
So not always hyperkalemia will cause acidosis.
Right.
With combined acidosis.
Right. So you have a defect in the serum in retaining the potassium ion. As a result, the patients have low serum potassium ion concentrations in type 1 and type 2. And in type 4, since the main cause is hypoaldosteronism, as a result, hypoaldosteronism, there is no direct problem with the defect of the renal tubules. So there is no absorption or reabsorption issue. As a result, in type 4, the patients have hyperkalemia. So the serum potassium is more.
Thank you.
Okay, you're welcome. Has everyone understood? So if I have to ask you, hyperkalemia or hypokalemia, keep in mind that metabolic acidosis or metabolic alkalosis can cause changes in potassium ion levels, depending if the patients have renal tubular acidosis or not. This is a very complex thing to master. Until and unless you guys come across questions, you guys will not be able to understand this. But metabolic acidosis or metabolic alkalosis can cause changes in potassium ion levels, depending if the patient has any renal tubular defects or not. Are we clear on this?
Yes.
Okay. Okay. Has everyone understood? Can we get a yes or no feedback? Okay, perfect. Thank you so much. Do you guys want to start pathology or keep pathology for tomorrow? Okay, so we don't even have one student who wants to start pathology. Okay, no problem. Can we start tomorrow, same time of today? Tomorrow, what we will do is we will try to start at 9 a.m. Okay, 9 a.m. is okay. If for some reason we have any changes of timings, we will let you know. So you have nothing to be worried about. And that's that. Okay, please always remember that no matter what happens, you guys will always get your 25 hours covered. So that is not a problem since we charge $1 per hour, $1 per hour. Okay, you guys will always get 25 hours no matter what. Okay, so 9 is okay. That's what we're going to do. Since we had a problem yesterday, I had to leave a bit earlier. That's why we did that extra 1 hour today. Okay, so that's that. And with that, if we take a, if we stop with the first aid right now, since we have just finished, the renal tubular, the renal physiology. Are you guys ready to start the UWorld notes? Are you guys ready to start the UWorld notes? Oh, 1 second while I prepare. Okay, is everyone ready? Could you please, okay, so we have another question from Dr. Hassan. Could you please answer my question? Okay, let's see what your question was. 1 second. The part about urine pH in type 2. Okay, so the part about the urinary pH in type 2. Let's see what happens in the urinary pH in type 2 is, okay, I understand what the main problem is. Do you remember how I told you that initially there will be increased amount of urinary pH that the bicarbonate will try to escape because there's a bicarbonate defect? Yes or no, Dr. Hassan? Do you remember that? That the main problem is the bicarbonate defect. But do you remember how I also told you that the alpha intercalated cells will try to make up the bicarbonate by releasing more hydrogen? Okay, perfect. So eventually what would happen is bicarbonate, when it gets very low, below the resorption threshold level, hydrogen ion secretion from alpha intercalated cells will increase, and this can cause urinary pH to decrease below 5.5. Okay, you are absolutely welcome. Next one, questions, doctor. Okay, Dr. Nikki, do we need to know the graph at the bottom of page number 592? Graph at the bottom of page number 592. Okay. Have not received a lot of questions regarding the graph at the bottom of page number 592. Okay, 1 second. Let's see. It's this graph you're talking about. Okay. Let's explain this graph. This is actually very easy to understand. Okay. Let me see who had the question. Dr. Nikki. Let me see who had the question. Okay, there was Dr. Nikki. Okay, good. So, Dr. Nikki, would you be kind enough to answer these questions? Okay, 1 second. Okay. Okay, so this question is for everyone, basically. This question is for everyone. Okay, what's going on over here is if we draw something like this, okay. Okay. Let's say that this is the bicarbonate level. Can you guys hear my voice? Can I get a yes or no? Yes.
Yes.
Okay.
Yes.
Okay. So the pH is increasing this way. The bicarbonate is increasing this way. Okay. Let's say that this is the normal set of value. Let's say this is close to 7.4 or 7. Well, we will just write 7. Anything less than 7, anything more than 7, that's that. Okay. Over here, if we have A, B, C, D. Okay. Can you guys tell me if A is acidosis or alkalosis?
Acidosis.
Acidosis. If we have to ask you, is A metabolic acidosis or respiratory acidosis? Because the bicarbonate is low.
Metabolic, yeah.
So
Metabolic.
This one over here is B. Bicarbonate is high, but the patient's pH is low. What type of an acidosis is this?
Respiratory.
Why is the bicarbonate increased in respiratory acidosis?
Compensation.
Very good.
As a compensation.
Very good. Over here is D an acidosis or an alkalosis?
Alkalosis.
This is respiratory alkalosis, correct?
Yeah.
Yeah. Low.
Yeah.
This is not respiratory.
It's metabolic.
Yeah, it's low. Yeah.
Is this
Yeah,
respiratory?
bicarbonate is low.
Low
Therefore, it is respiratory alkalosis.
Respiratory.
Respiratory.
Okay, I was just trying to confuse you.
Yeah.
Okay, this is respiratory alkalosis. Very good. If this is respiratory alkalosis, then this is also respiratory alkalosis, correct?
Metabolic alkalosis.
Metabolic
Metabolic
alkalosis. Should be metabolic.
Okay. So this is basically the breakdown of the graph. Okay, this is
What about mixed?
the breakdown of the graph. Okay, now what we will do is we will talk about mixed. Very good. Very good. If we have to talk about mixed, if there's a mixed acidosis or a mixed alkalosis, let's say that we draw another line over here. Okay, let's say that we draw another line all the way through over here. Okay. This line is the line for partial pressure of carbon dioxide. This line is the line for partial pressure of carbon dioxide. And if we draw another line over here, this line is the line of buffer. Okay, now my question is, what is buffer? Buffer. What do you mean by buffer?
Compensation.
Buffer, can we say that
It's compensation.
For compensation.
what is the best buffer of the blood? Number one.
Bicarbonate.
Bicarbonate. Very good. Bicarbonate is the number one buffer. I mean, the buffer. I said buffer. It's buffer. Okay. So number one buffer of the blood, that is bicarbonate. Okay. So basically, the buffer is basically anything which tries to maintain the pH at a normal level is buffer. If it goes too high, it can bring it to a normal level. If it goes too low, this is the normal level. So this is the buffer time, the time for the pH to come to a normal level. And this is the graph for PCO2. That is, with increased amount of partial pressure of carbon dioxide, if carbon dioxide increases, will there be, if the partial pressure of carbon dioxide increases, what happens is, like over time, there is decreased amount of pH. Okay, so this is basically the PCO2. Although over here, what you can see is pH is increasing, but what happens is that the partial pressure of carbon dioxide stays at a normal level. Partial pressure of carbon dioxide stays at a normal level. So the thing is, partial pressure of carbon dioxide, let's say it's at 40. Okay, if I have to ask you that now you have E and you have F. Obviously, if this intervenes in between the respiratory and metabolic acidosis, is this a normal acidosis or a mixed acidosis? E, is it mixed or normal?
Mixed.
Mixed acidosis, obviously, because it's between the respiratory acidosis and the metabolic acidosis. Over here, if I have to ask you F is between metabolic alkalosis and respiratory alkalosis. Is F mixed or is F
Mixed alkalosis.
It's a mix. But you will, but let me tell you what the question you will receive in UWorld. UWorld will never ask you about mixed acidosis and mixed alkalosis. What UWorld will ask you is, UWorld will directly ask you, nope, UWorld will directly have questions, one question at max. And that's why it's not that important. 1 to 2 questions at max, that pH, HCO3, they will have A, B, C, D. That's it, nothing else. And they will only ask you which one is A, which one is B, which one is C, which one is D. A is respiratory acidosis, C is metabolic acidosis, B is metabolic alkalosis, D is respiratory alkalosis. This is the only question you will get in UWorld. Are we clear?
Yes.
Okay. Do we have any other confusion or? Okay, do we have any other confusion? Yes or no?
Yeah, I have a question, doctor.
Yes, what is your question, please?
In the hyperkalemic tubular acidosis type 4, we said the excretion of ammonium ion is low, and the urine pH is low.
Right.
Therefore, I couldn't get it, because if the ammonium ion excretion in the urine is low, we expect urinary alkalosis.
Right. But over here, the urinary pH is low. The urinary pH is basically low, or the urinary pH is basically variable. I'm pretty sure they have written variable over here. You see
Yes,
this?
they're written by.
It could be low, it could be high, or variable. So that's why this is the main problem with renal tubular acidosis type 4. Everything is abnormal over here. Where you would have expected increased amount of ammonia, there is decreased amount of ammonia.
Yeah.
Where you would have expected urinary pH to be high, urinary pH is kind of low. Okay, and urinary pH is low, or
Yes.
urinary pH should actually be high. So it's actually variable.
Okay, thank you.
Okay.
Yeah.
Okay, for the purpose of your UWorld, type 1 is very important. Type 1 is very important, and so is type 2. Type 4 is not that commonly asked, because type 4 can come with a lot of confusion and problems, and examiners know this. So they do not make a lot of questions from type 4, they make all the questions from type 1 and type 2. Okay. Are we clear?
Yeah.
Okay, perfect. Thank you, Dr. Adhanom, for asking the questions and getting it cleared out. Okay, we already have 5 or 6 students who has left the lecture because it's actually getting pretty late. Would you guys be interested in going to the UWorld questions instead of the UWorld notes for today?
Yes, doctor. Yes, it's better, I think.
Okay, yes. Everyone is okay. Everyone is tired. No one wants to do questions anymore. No one wants to study notes anymore. So what we can do is we can jump on to the UWorld questions. Okay, so that's what we will do. So in order for me to prepare the UWorld question, give me 2 minutes.
Mucho tan fuerte. ¿Escuchaste? Caramba. La puerta creo que es. Los de abajo aquí. No, creo que alguien no toca la puerta. No, la música de
Sí,
aquí.
pero alguien la tocó
No,
también.
nadie tocó. Yo he hecho esto.
¿Ah, tú has hecho?
Sí. Fuerte está de... se
sí,
apagan
eso
estos.
es.
No hay nada, ¿no?
Sabemos cómo vamos.
Pucha.
Yo ya sabemos que los latinos son de acá. Los latinos son de acá. Debe estar pasando ese algo.
Ya vamos a acabar ya. We have to do questions.
Okay, so can you guys hear my voice? Okay. Okay, 1 second. Okay, is everyone ready to begin? The 5 UWorld questions regarding the renal system, yes or no? Okay, you guys have the liberty to unmute yourself and answer the question. We're only going to ask you to answer, please answer then, so that it gives everyone a chance, okay? Is everyone ready, yes or no?
Yes.
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 Okay, let's begin. First question, we will read the last line first. If these new signs and symptoms are caused by drug toxicity, they are most likely related to which of the following? A 47-year-old man comes to the emergency department due to fever, fatigue, history of HIV, not been taking antiretrovirals, his temperature, blood pressure, pulse is 104. Okay, respiration is 20, physical examination for hepatosplenomegaly, laboratory study shows pancytopenia, intravenous amphotericin is initiated for histoplasmosis. What is your answer, Richard?
Renal tubular dysfunction.
Which one?
Type 1.
E.
Okay, which one? Which renal tubular dysfunction?
Type 1.
Very
It's type 1.
Type 1.
Type 1 renal tubular dysfunction. Because of amphotericin toxicity.
Amphotericin B toxicity.
Very good. Okay. Next one.
And why they mentioned extra beat, doctor, in ECG? Because of kalemia, something?
Yes, right. But it was not important. They wanted to confuse you. Okay.
Confused.
Okay, next one. Which of the following medications most likely contributed to this patient's hearing impairment? Okay, ototoxicity. You guys can answer this question already from over here. Which drug is ototoxic?
Digoxin.
Aminoglycosides.
There is no aminoglycoside.
No aminoglycoside here.
Furosemide.
Furosemide exacerbates that.
Furosemide. See.
Let's
I
read
think
the
furosemide.
Thiazide.
Okay, let's read the question. The question is difficulty hearing. She was admitted with signs symptoms of what looks like as heart failure. Family members reported that she has been tuning her TV volume, turning her volume, and they have to speak loudly. Her hearing was normal. Her medication problems includes hypertension, heart failure, and CKD. Examination shows moderate bilateral sensory neural hearing loss. Now, which of the following is the patient's hearing impairment? Number 1 cause of ototoxicity is amphotericin. Number 2 is?
Furosemide.
Very good.
Furosemide.
Furosemide is the number 2 cause of ototoxicity. Okay. And the thing is, first and foremost, this patient was treated. Let's look at this. Her family members reported her
heart failure,
normal medications, heart failure, examination shows bilateral. Okay. And the thing is, she was admitted 1 week for dyspnea, orthopnea, and bilateral leg swelling, which has been slowly improving with treatment. What will you prescribe to a patient who has heart failure? Furosemide.
Diuretics.
Furosemide is spironolactone.
Furosemide. No. You will prescribe the furosemide because the patient has dyspnea or bilateral leg swelling.
Yeah, abdominal edema.
Along with this, spironolactone cannot cause ototoxicity. So the patient was obviously prescribed furosemide because we use hydrochlorothiazide for primary hypertension. We do not use thiazide for heart failure. Do you understand that there's a clue over here? Who is heart failure?
Yeah.
That's a clue. Okay.
Clue, yeah.
Next one. Which of the following medications did this patient most likely ingest? Okay. Let's see what's going on over here. A 27-year-old nursing assistant with a history of MDD and bulimia is brought to the emergency after a suicide attempt. She claims to have ingested several diuretics. So everything is a diuretic over here. Okay. The patient complains of frequent large volume urination that started shortly after she ingested the pill. She has also been thirsty and she denies nausea, vomiting, or diarrhea. Her temperature is 36.7. Okay. What's going on over here? Let's see. Sodium is low. Potassium is low.
Potassium.
Okay. Chloride, bicarbonate. Creatinine is sort of high. Calcium is high. Albumin. Okay. Calcium is high.
Thiazide.
Which of the
Thiazide.
following? Very good.
Hydro C.
Why is it C?
Because of
Hyperkalemia.
hypercalcemia.
Very good. The calcium level is high, and thiazide causes hypercalcemia and hypocalciuria. Has everyone understood why the answer is thiazide?
Yes.
Yes. Yeah.
Okay, very good.
To make the faces, I flip one of these over, and I'm just gonna
Next one.
the outline of the white part of Nathan's face onto here.
Which of the following medications is most likely to prevent recurrent stone formation in this patient? Easy
Answer we can know from this sentence.
Easy question. Okay, but let's see what's going on over here. Okay, I know a lot of you think it's acidozolamide. Let's see what.
Yeah.
A 46-year-old man comes to the emergency department with flank pain and hematuria. The pain is similar to several previous episodes when he was diagnosed with kidney stones. Abdominal imaging shows a radiopacity in the right ureter. The patient is admitted to the hospital and started on intravenous hydration and analgesic. He subsequently passes the stones and becomes asymptomatic. Chemical analysis reveals a calcium oxalate composition. Now, what is your diagnosis?
Come on. Like, what's the answer?
Acidozolamide.
Hydrochlorothiazide.
C.
Why is it C?
F cannot be answered, so it has to be A or
Yeah,
D.
because you don't want calcium to be in the urine to form those stones.
It's
I'm
C,
sorry?
doctor.
Why is the answer C?
Hypercalcemia.
Because thiazide prevent calcium passage in urine.
Yes, thiazide.
But here it's written which drug is likely to prevent.
Okay, one second. Can we get one student to answer this?
Hydrochlorothiazide.
I can answer, doctor.
Okay, so Dr. Hossam can answer, but before Dr. Hossam starts, he has participated a lot. So let's give another physician a chance. The doctor who said hydrochlorothiazide, the female physician, is it possible for you to give a proper explanation why it's hydrochlorothiazide?
Yes, because thiazide diuretic cause hypercalcemia.
Okay, then?
But doctor, here they want a drug that prevent recurrent stone formation.
You have a different answer.
The calcium in the
Okay.
absorbed.
I think
Hydrochlorothiazide causes reduced urinary
Time is up.
calcium.
Okay, your time is up. Okay, let me tell you what the correct answer is.
Prevent
Hydrochlorothiazide. Why is hydrochlorothiazide the correct answer? Hydrochlorothiazide is the correct answer because hypercalcemic patients for a long period of time will have formation of calcium oxalate stone. If it was furosemide, which was causing hypercalciuria, this would have been a calcium phosphate stone or any other stone. Are we clear? Calcium oxalate stone is due to hypercalcemia.
Doctor, you said
Why acetazolamide
you
is
said
not correct?
hydrochlorothiazide make hypercalcemia, right?
Right.
Okay, but here we want a drug that prevent recurrent stone formation.
Thiazide cause calcium absorption, not secretion.
I know, but the long-term hypercalcemia in the blood, if there's high amount of calcium in the blood, this high amount of calcium, what this will do, this high amount of calcium, what this high amount of calcium will do is they will bind with the oxalate and then they will be released in the urine. So this results in the formation of a calcium oxalate stone. If it was furosemide, which was causing hypercalciuria, you would also have calcium stones, but in that case, it would have been calcium phosphate stones, not calcium oxalate stones. Okay. Now, Dr. Mohammed, what was your question, please?
So the hydrochlorothiazide excretes the oxalates, yes, and because they combine to the calcium, so we give hydrochlorothiazide.
Right.
Thank you, doctor.
Okay.
Thiazide is used to treat hypercalciuria. Is that right?
Hypercalciuria, yes, it is right. So hypercalciuria is treated with hydrochlorothiazide. But when you give a patient hydrochlorothiazide, does it increase the hypercalcium? I mean, does it cause hypercalcemia? Yes or no?
Yes.
Okay. So if you have
Yes.
high amount of calcium in the blood, this hypercalcemia stones will have calcium oxalate composition. If it was the stone due to hypercalciuria, then the stone would have been a calcium phosphate composition.
All right. Thank you.
I have a question, doctor.
Yes. What is your
So
question?
so in the last line, it's saying which of the following medications is likely to prevent recurrent stone formation for the future.
Right.
So if we're saying that thiazide cause stone formation, wouldn't this aggravate the condition again?
Right, this will aggravate it, but primarily if we give hydrochlorothiazide, what will happen is the hydrochlorothiazide will be used to take away the stone, take away the calcium from the tubular urine, and as a result, primarily it will decrease the calcium in the tubular lumen, and it will prevent recurrent stone formation. Although, having said that, hydrochlorothiazide again can cause your calcium stones. And the thing is, the stones that are formed in hydrochlorothiazide are due to the oxalate that is present, which causes calcium oxalate stone. If furosemide was involved in causing the stone would have been calcium phosphate stones. That's all I'm trying to say, that there are two types of stone composition, calcium phosphate and calcium oxalate. Calcium oxalate stones are formed due to hypercalcemia.
Got it.
Okay,
Thank
and
you.
at the same time, thiazide can also prevent the stone formation by absorbing the calcium from the urine. So thiazide is the right answer.
Got it. Thank you.
Okay. Does anyone have any other question?
Yes.
Yes. What is your question, please?
Yeah, if I make the urine alkaline by acetazolamide, this not prevent calcium stone?
This will not prevent calcium stone formation. This will actually result in the formation of more calcium stone. Okay, because calcium deposition occurs in alkaline condition. Are we clear?
Okay, thank you.
Okay. Does anyone have any more questions? Any more questions? Yes or no?
No.
Okay, no more questions. Okay. Last question. Okay, last question. Only when you say you're ready, please answer the question. First of all, let's read the question. Administration of which of the following drugs is most likely responsible for the change in the patient's renal function? A 59-year-old man who is being treated for hypercholesterolemia, diabetes, and hypertension comes to the physician for a scheduled follow-up visit 3 weeks after starting a new medication. He has no new complaints, okay? First of all, you read the last line, then you underline the important words over here. Okay, can you guys tell me what is the important words from the first sentence?
Treated for hypercholesterolemia.
Hypercholesterolemia, diabetes,
tension.
So this patient has a past history of these problems. No new complaints. Blood work drawn yesterday shows an interim increase in potassium from 4.8 to 5.2. Is this important to underline? Yes or no?
Yes.
Very important. 4.2 or 5. And a creatinine elevation from 1.2 to 1.6. Which of the following drugs is most likely responsible for this change in renal function? Do not tell me the answer. Tell me you're ready and I will ask you.
I'm ready.
Okay.
Ready.
Okay, so the first doctor who said ready, what is your answer?
Lisinopril.
Everyone else agree with, is it Dr. Adeno?
Yeah.
Okay, does everyone agree with Dr. Adeno?
Yes.
Yes.
Okay, why is it not, okay, so I'm not gonna go into the depth of this. Dr. Adeno is absolutely correct. Okay, congratulations to Dr. Adeno and all the other students who thinks lisinopril is the right answer, because lisinopril is an ACE inhibitor. It prevents the formation of aldosterone. If aldosterone is not forming, then the potassium is not secreted. As a result, the potassium builds up in the blood and there is hyperkalemia. Okay.
And there is decrease of filtration. That's why creatinine, yes?
Right. Are we clear on this?
Yes.
Okay.
And he had hypertension, so we give him ACE inhibitor.
Right. Since the patient has hypertension, that's why he's taking ACE inhibitors.
Diabetes with hypertension.
Right. The patient has hypertension. That's why the patient is having lisinopril. For lisinopril, the patient has hyperkalemia. Are we clear on this?
Doctor, but out of all these drugs, I think if you see only the creatine change, metformin and hydrochlorothiazide are the two drugs which will result in increase in creatine, I guess, right?
Right, but the main problem over here is the patient's change in renal function. The main problem over here is that the creatinine change from 1.2 to 1.6, is this more clinically significant, or 4.8 to 5.2, is this more clinically significant?
Hydrochlorothiazide will not work if it's greater than that. Yes, I got it now.
Right.
Yeah, yes.
No, but my question is, if the patient has changes in potassium ion level, is this more clinically significant, or changes
I
in...
think the potassium is more clinically than creatinine.
Exactly.
Less
So
than
this is of higher concern, 4.8.
than the creatinine.
Right. So we have to consider the drug which is causing the hyperkalemia first. Then we can consider any drugs which can change the creatinine level. It could be lisinopril, it could be thiazide, it could be any other drug. But the question and concern is the change in potassium, 4.8 to 5.2, and the drugs which are responsible is lisinopril. Are we clear on this? Okay. So with that being said, thank you so much for doing the lecture and finishing the lecture with us. Okay, does anyone have any other questions before we end the session for today? Does anyone
Doctor,
have...
so tomorrow we start at 8 a.m. or?
No, tomorrow we start at 9 a.m.
Okay.
Okay, we start at 9 a.m. And first and foremost, thank you so much. Let me thank you for all your attention that you have provided. And have you guys understood the renal physiology that we have studied today? Yes or no? Okay. Are you guys watching Patoma videos? Okay, good. Okay, has everyone of the new students received our lesson schedule, which has a full breakdown of how you should study at home? Has the new students received our lesson schedule? Okay, first of all, let me identify the new students. Who are the new students? We have Dr. Omar Ahmed. By new students, I mean students. Of course, I will add you to our Facebook group. Please send me, what is your name on Facebook? What is your name on Facebook, Dr. Ahmed? Oh, USMLE score. Okay, USMLE score. Okay, I will add you to the group. Okay, good. Now let's see if the new students, could you please identify yourselves so that we can send you the lesson schedule who has not received our lesson schedules of how your day in the life of studying USMLE Step 1 should look like. New students who has not received the lesson schedule. Okay, who else? Okay, we will identify, okay, Dr. said, okay. So we will identify the new students and we will send them the lesson schedule, which contains the breakdown of how much you should study. And let me thank you for doing the class for today. Hopefully you guys have understood. Please do the UWorld questions or else you will forget every information from the renal chapter. With that being said, yes, okay, we will send you the email for Dr. Najib, no problem. We selected 5 students for this week. We will select 5 more students for next week. And eventually when we start basic sciences, we will have our subscription for physio ready, and then we will be able to share the physio subscriptions with you all. Okay. And the 5 students who were selected for this week was selected by our team at random. And every one of the students will get the Dr. Najib lectures. So that is nothing to be worried about. Okay, so everyone will get the Dr. Najib lectures. Next week, we will have more students who will get the lectures. And once you get the subscription, please download the videos you need and then
pass it on to your next friend in class. Okay, hope you guys have a great day today. Okay, make sure you do the questions. Let me know if you have any questions by sending us an email. Okay, best of luck to you all. And if all goes well, we will see you tomorrow at 9 a.m. in the morning. Okay, thank you.